All right, welcome everybody to our second meeting of the Cost Growth Target Advisory Committee. Welcome back, and a couple of you, this is your first meeting, so thanks for joining. Excited to have you here with us, and we'll do some introductions as well. A couple of housekeeping notes. This meeting is being recorded. We do have the chat open, so if you're having any technical difficulties, feel free to message Brian Toops, who is providing meeting support for us today. Also, if you are presenting and need any facilitation, Brian is managing all of that for us. So thanks, Brian. All right, committee members, if you can and you're comfortable and you have bandwidth to do so, please keep your video on. That is appreciated. And all other folks who are not speaking or presenting or providing public comments, please turn your videos off so that we keep the focus on the committee discussion. And I think those were the logistics. All the meeting materials are on the website. Committee members, you received 2 emails from me that have all of those materials, and we are going to start walking through them. So let's go to the next slide and review today's agenda. So we have a couple of housekeeping updates and a couple of program updates that we want to run through with you, some committee business, as well as where we are with the program. We're going to spend the first half of the meeting digging into our new report that was published this morning. This is our 2013 to 19 cost trends and cost growth drivers report. We'll have public comment at 3:30. We'll take a break, and then we'll spend the last hour of the meeting digging into the value-based payment compact and how we're doing on progress towards value-based payment targets and what the next steps are for that body of work. Any questions about today's agenda? Okay, excellent. Let's go to the next slide. So I was thinking that for the sake of time, maybe we would have the folks whose meeting, this was your first committee meeting, introduce themselves first, and then we'll see how we're doing on that. So I think Morgan and Peter, would you like to introduce yourself to the full committee?
Sure. Hi, everybody. My name is Morgan Beltz. I'm with the Oregon Business and Industry. We're the largest statewide business association, and we represent over 1,600 members who employ more than 250,000 Oregonians. Our members are from all over the state, from all different sectors, and over 80% of them are small businesses. So I'm really excited to participate in this and represent them.
Good afternoon. I'm Peter Davidson. I'm the CFO of Pacific Source. Pacific Source offers insurance in Medicaid, Medicare, and commercial across 4 states. And I've been with the company for about 15 years.
I think we probably are okay on time and could run through quick introductions for all the committee members. So shall we just go down the list? Michael, are you with us today?
I am. Hi, everyone. I'm Michael Anderson Mathy. I use he, him, his pronouns, and I am an independent consultant that does a lot of work around equity. And I was a member of the Health Equity Committee for 4 years and have worked in the CCO.
Melissa.
Hi, I'm Melissa Dahm. I'm the CFO for the delivery system in Oregon for Providence Health and Services. I use she, her, hers pronouns, and nice to meet everyone.
Angela.
Good afternoon, everybody. I'm Angela Dowling, president of Regions Blue Cross Blue Shield. I've been in this role for about 8 years, and I use the she, her pronouns.
Ivy.
Oh, hi, is it my turn? Sorry, taking notes. Hi, Ivy Jar Goldman, she, her, consumer. Thank you.
Lawrence.
Lawrence Brunstall, he, him. I am Executive Vice President and University Chief Financial Officer at OHSU, and have been in that role for 11 years now.
Mary Beth.
Hi, I'm Mary Beth Garino, she, her pronouns, and I am the healthcare advocate with OSPERG.
Lisa.
Hi, I'm Felisa Higgins. I'm the political director at SEIU. I've been there 18 years. I use she, her, they, them pronouns.
Jason? Do you have your audio fixed yet? Okay, we'll come back to Jason. Jim?
Thank you, Sarah. I'm Jim Hauser, retired auto repair shop owner and co-chair of the Main Street Alliance of Oregon. Thank you.
Hirdesh?
Yes, this is Hirdesh Lal. I'm a finance officer and senior director of product contracting with Kaiser Permanente. Been with Kaiser Permanente for about a little over 20 years, and been with the CMS and with regions and with providers before.
Great. Teresa? There you go.
Hello, sorry, I joined a little bit late, so I assume we're introducing ourselves. I'm Teresa Learn, Chief Financial Officer at Care Oregon.
Stefan is not available for the first part of the meeting today, joining us a little bit later. Gil?
Hi, good afternoon. Gil Munoz, CEO of Virginia Garcia Memorial Health Center. Been the organization about 31 years now.
Nick?
Hi, my name is Nick Powers, CEO at Winding Waters Clinic and F2HC out in Northeast Oregon. Been with the clinic for about 15 years and helped to bring it to that F2HC status.
And Shannon?
Hi, I'm Shannon Saldivar. I'm an insurance agent owner in the Dalles here in the Columbia River Gorge.
Karis?
Good afternoon, Karis Stoudemire Phillips, Vice President of the EI and Community Initiatives at Moda Health, and I've been there 11 years. And I use she, her pronouns.
Greg?
Hi, my name is Greg Sutliff, and I'm the Finance and Operations Director at Project Access Now. And I've been here for a little over a year and a half, and my pronouns are they, them, and theirs.
Julie?
Hi, Julie Weller, she, her, oversee plan design and strategy at Intel, been here 26 years.
Great. Jason, audio fixed yet?
Can you hear me?
Yes.
All right. New laptop troubles. So yes, Jason Hawkins, 5 years at Peace Harbor Medical Center in Florence, Oregon. He, him.
Great.
Thank you.
And our ex officio members, Pat Allen will be joining us in about 20, 30 more minutes. Mark McMullen is not here today. And Andrew, you're up.
Hi, good afternoon, everyone. Andrew Stolfi, use he, him pronouns. I'm the director of the state's Department of Consumer and Business Services and the State Insurance Commissioner.
All right. Jeremy, do you want to introduce yourself?
Sure. Jeremy Van Hayen, the Director of the Health Policy and Analytics Division with OHA, and good to see you all. And thank you all again for your commitment to this work. I gave a long speech last time, so I won't repeat it, but good to see you all.
Great. And I'm pretty sure I've talked to all of you extensively at this point, but I'm Sarah Bartleman, Cost Growth Target Program Manager at OHA, she, her pronouns, and I'm going to facilitate the first part of this meeting. So, okay, introductions. Glad you are all here. Thank you again for your commitment to this work and for making the time for our committee meetings. And let's go ahead and dig in. So next slide, please, Brian. I have a couple of quick housekeeping updates for you. In the meeting packet for today, we sent out a draft summary of the June meeting. It's pretty detailed. We had a good discussion. So those of you who weren't able to make the first meeting, please take a look at that summary. The recording is also available online. Just wanted to pause and see if anyone had any questions or corrections to the June meeting summary that you want to raise. Okay, seeing heads nodding. I don't think we want to formally vote to approve or anything like that. Just want to make sure that everyone feels like it accurately captured the discussion. So great, June meeting minutes, meeting summary done. Also in the meeting packet was the final charter. So last month you agreed to approve the charter with the several changes and additions that were discussed. Those have been incorporated and the final charter is just in the meeting packet for reference. So we're not going to dig back into that, but it is now available and on the website, and we have blocked that down. So thanks. Questions about the charter? Okay, next slide. We also talked last week about group agreements. So these would be the behaviors and actions that we agree to exhibit as we work together as advisory committee members. We had a couple of additions and suggestions that people made at the end of last month's meeting. So you can now see the updated list here on the slide. We've also attached this list of group agreements to the end of the agenda. So it will now be part of our agenda going forward. Pausing here to see if there are any additional edits or additions to these group agreements. Do the changes we've made since last month reflect the discussion that we had? Any concerns about this framing or adopting this in our work going forward together? Okay, all of your heads are shaking. This is great. You're making it really easy for me today. Thank you. Okay, next slide. So we also asked you last month about co-chair selection. We reviewed the duties and the responsibilities for the co-chairs and how they would work with staff in supporting these meetings. We asked if folks were interested in self-nominating or if they would like to nominate other members of the committee to serve as the co-chairs, to let us know over email after the June committee meeting. We had a couple of suggestions come in. Not many people really wanted to self-nominate, so a couple of nominations from peers that popped up. Remember last month we talked about having an industry representative as one of the co-chairs and a non-industry representative as the other co-chair. So today we are happy to announce that Felisa will be our co-chair on the non-industry side. And we are going to spend a few more weeks to continue conversations and figure out the industry co-chair. So Felisa, I think we are going to hand things over to you today for facilitation help and jumping right in on that. And hopefully we'll have you have a co-chair joining you for our September meeting.
I would really like a co-chair to join me for our September meeting. So if you aren't feeling the spirit, hopefully I can motivate you. I'm a kind person most of the time and I'm easy to work with. So please think about being a co-chair with me for the September meeting.
You would like to be a co-chair, please send us an email, let us know. And if we don't get any emails, we will start reaching out to people. And I know Bill Kramer from the policy board as our liaison is on, and I'm sure he has some ideas about who can serve as the co-chair with Felisa. So Felisa, thank you for being willing to take this on and leading the group over the next period of meetings.
Great. So a couple of things I think as we run through the rest of the agenda, I feel like as I looked at the agenda and reviewed it with Sarah, I think that there's a lot of information that we're going to have as we go through today. I would prefer if people kind of jump in and ask questions as we go along. I think what's really helpful in this group setting is if people use the raise your hand function, because then that actually puts you in a queue. And it's much easier to call on you. If you don't know how to use that in Zoom, I'm just going to go over that really quickly. At the bottom of your screen in black, you have a little happy face situation, and under it, it says reactions. If you click on that once, you'll see reaction options, which please feel free to use throughout the meeting. Makes it more fun for everyone involved. And since this is being recorded, that's always nice. And then underneath that, you'll see a raise your hand function. Once you raise your hand, you'll be put in the queue. You get sort of kicked to the top of the screen so we can go through any comments, questions, etc. in the order that you get in that raise your hand queue. And remember, after you've had your chance to speak, it's always helpful to lower your hand. And then that way you go back into the general mix. Otherwise, you kind of just sit there and then we keep going back to you and asking, do you still have any questions? So hopefully everybody can see that. If you can't see that or have questions about that, please jump in here in the chat and we can help you or maybe potentially send you some screenshots after the meeting. I don't want that to be the only way that people jump into the queue. If you're not able to raise your hand, please, you can also physically raise your hand and I'll do my best to try to see you, although I'm operating off of the screen situation. So that's always a mystery sometimes, or if I don't see you, then please come off mute and just jump in so that we can hear you, and I'll make sure to get you in the queue. Are there any questions or thoughts about that? Great. Well, the nice thing about this meeting is we don't have a lot of decision making that needs to happen. which is helpful since I'm the only co-chair right now, but I do want folks to know that we are going to be operating off that modified consensus model that we agreed to. And so I'm going to do my best to facilitate these meetings to reach consensus and to have a robust enough discussion so that we're all clear when we can't reach consensus and need to move forward. So the next piece on the agenda, we can go to the next slide, is we're going to do a round of program updates. And I actually don't know the name of the staff person, so I'm just going to kick it back to Sarah.
It's me. Thanks. Okay, so we wanted to give you a couple of updates on just things that are happening for program implementation as we continue to roll out the cost growth target program and work on data collection, validation, and reporting. So next slide, please. We put out the manual and the template and have begun the process for this year's data collection or data submission if you are a payer. So the way the program works, every year we will identify the payers that have a certain number of covered lives in Oregon. Those payers are mandatory reporters and need to submit data to the cost growth target program. We've identified 38 unique payers who need to submit data in 2022. That's 19 parent entities. So there's some nuance there between the parent entity versus the unique payer and the line of business or the market that they're offering. This year's data submission is due on Friday, September 2nd. We've held our training for the data submitters in June. The manual, all of the guidance, frequently asked questions, all of that has been posted. We've also held our first office hours session and we'll do a second office hours session later this summer. This 22 data submission includes spending in calendar year 2020 and 2021. So that's what we'll be collecting and validating later this fall. Any questions about the data submission? Okay, next slide. We have also been working this summer on connecting with provider organizations. So the cost growth target applies at 4 levels: state, market, provider, payers, and large provider organizations. We had previously talked about the criteria for those provider organizations. We have identified 52 provider organizations across Oregon that meet the criteria for inclusion as currently defined based on that initial data that we collected last fall. So calendar years 18, 19, and 20 data. We have been reaching out to those 52 provider organizations and setting up individual meetings with them. And in those meetings, we have been giving an overview of the cost growth target program. We've been answering questions and talking about what this means. Why are you hearing from us? What does it mean to be included in this program? And then we've been sharing data, a data output of that 18, 19, and 20 data. And we're having conversations that are like, if the cost growth target applied in these years, which it doesn't, these are the questions we would be asking. This is what your cost growth was. This is what it looks like some of the cost growth drivers might have been. These are the kinds of follow-up questions we might have. So really treating this summer as a practice run before next year when we will get to payer and provider level public reporting. We provided a mock-up of what that provider level data looks like, and the link is here on the slide. We're not going to show it, but if you're curious about the level of data that we're sharing with provider organizations and what the back and forth looks like this summer, there's an example with some fake data. Next slide. And then as we're having these conversations, we've had about 27 of them now, representing most of the attributed lives in the state. We have a handful of very large organizations with lots of attributed lives, and then a very long tail of smaller provider organizations that have 1 or 2% of the attributed lives. So as we're working through that long tail, we're starting to have really similar conversations, and we wanted to highlight a couple of key themes that we're hearing in those conversations with providers. So one is that our attribution approach is generally successful. It's generally working. So this was a bit of a test. We didn't know if our plan was going to work to collect data from the payers and then roll it up at the provider level. And generally speaking, it is working. The providers are telling us that ballpark and directionally, we are more or less what they would expect to see based on, we're not including uninsured members. And so when you take that into account, roughly we're shaking out what people would expect to see in their data. Things line up with what contracting arrangements look like, who the major payers are. So we're feeling pretty good about that as a validation check of our process. We're also having some conversations about the variation and understanding the variation across the state in payer and provider organization data sharing. So some provider organizations have existing data feeds that they're getting from payers. They are getting monthly lists of attributed patients. They're getting total cost of care reporting. They have a lot more insight into who their high cost patients are or high cost episodes, whatever that looks like. Other cases, the provider organizations don't have those connections with the payers, and they look at our data and they say, we need more information. This data is not actionable. If we're only getting it once a year and it's 2 years after the fact, how can we address our high cost patients? How can we work on these cost containment efforts? So we've been talking with the provider organizations about where we can possibly create some additional connections with payers. Where are there opportunities to build some additional data sharing that would help provide more insight into that conversation? But just noting that there's a lot of variation across the state in what those relationships and data sharing arrangements look like, and that more granular actionable data is a common need that is arising. And then finally, and probably not unexpected at all, we are hearing concerns about cost growth drivers that are outside of a provider organization's control. So things related to COVID-19, things related to workforce and labor costs, concerns about growing inflation and how that will show up in the data, how the program will take all of those things into account, and what all of that means for an organization and future accountability under the cost growth target program. And Lawrence, I see your hand, so let me say one more thing and then open it to you. I think I want to call your attention to the written public comment that was submitted by Salem Health. We sent it out this morning. It's also on our website. I think these themes, really, I wrote these themes before I saw Salem Health's letter, and I think they absolutely highlighted and even went into more detail on at least the data sharing, the need for more granular data, and these concerns about sort of the current environment we're in. So I think for a very specific provider organization perspective on that, I really call your attention to that Salem Health letter. Lawrence.
Thank you, Sarah. I was going to make this comment later, but I think you just called it out here, so it's, I think, a perfect time to do it. From the perspective of a provider, all the great data that we're about to see that I've looked at, at least preliminarily, is really about the price of healthcare, and not the cost of healthcare, the cost of providing healthcare. And I think this is a point made here. It's made in the Salem Health letter, I think, and it's one I just wanted to note. And I think it would be really, so for example, at OHSU, and I think this is generally true, about 60% of the cost is labor costs, nurses and pharmacists and respiratory therapists and food service workers, logistic workers. About 20% of the costs are pharmacy and medical supply costs. And the remaining 20% is split between about 6% capital and 14% other costs. And, those having been, I wouldn't say stable, but reasonably consistent for, at least a decade pre-COVID, are in remarkable change right now. And I wonder if we could, the sort of comment I'd like to make is that if we could round out the really impressive and helpful sort of price data that we're about to see with underlying cost data as well, like, what are the labor cost trends? What are the pharmacy and medical supply cost trends? What are the capital need trends? I think it would really give a rounded picture. And so I just wanted to put that marker down for the committee's consideration. Thank you.
Thank you for that. And I will say that I didn't call this out as a key theme, but it absolutely is something that comes up regularly in our provider organization conversations. We're essentially measuring through the cost growth target program provider revenue, not provider operating costs. And those are very distinct. And there are a lot of distinctions that we need to make between them and what's in a given measurement and what's not. And I think talking about additional reporting or analysis, that is one of the questions that we want to ask you as a prompt. What else would be helpful to see? So thank you for putting that stake in the ground now. Melissa.
Yeah, just on that comment, I also want to be sensitive to, it's what the allowable is by the payer, not actually what the revenue is and collected by a provider. So that terminology is also important, as in some organizations, we've seen what's, actually collected from a out of pocket more than, anyway, as those changes. So I just think the sensitivity around revenue versus what the insurance company has agreed to from an allowable standpoint in a contract can be very different things.
Yep, and you're right, we are measuring the allowed amount in the cost growth target program. Okay, go ahead.
So Sarah, just before you move on, I just want to give an opportunity for other folks to jump in here if there's questions, and then I do have one, I think a little bit of a summary. So is there anyone else who has questions or thoughts on submissions or the data that Sarah has outlined? Any comments on some of the successes that I think a lot of folks, I know Angela was on the previous committee, was worried about the sort of, could we meet the attribution model, which was a big question. And that seems to be one of the successes. Any other thoughts on that?
Yeah, actually, can I double down on the attribution success? Because when we looked at Massachusetts and some of the other states that have done attribution for their work, they were only able to attribute around 20 to 30% of covered lives. Our attribution in this 18-19-20 period is closer to 60%. And I think that really speaks to how much Oregon has adopted both primary patient-centered primary care home enrollment models, as well as value-based payment contracting, which we'll talk more about. And both of those really have bumped our attribution, and we have a majority of the covered lives reflected in the provider organization data.
Mary Beth.
Yeah, just a quick question related to Sarah, what you just said. Is that, I mean, you just said it was because of like patient-centered primary care homes and other things that Oregon has done. So do you think that that's replicable throughout the program in next year or the year after that as we continue with this program?
Yeah, I think we'll expect to see our attribution stay around this ballpark. I think there might be some tightening of it as we understand. Certainly one question that provider organizations ask us in these meetings are, and then now can you tell us exactly who these patients are that have been attributed to us so that we can go look at their costs or their quality of care, what's happening. We don't have that individual level data to spit out a patient list, but again, that's where the patient or where the payer provider organization data sharing conversations can come in, because in some cases those patient lists or rosters can be provided.
Great, thanks.
Okay, I'm not seeing any other hands jump in here or other thoughts. And I know some of the issues that Lawrence just raised, actually, some of them actually come in other reports. So Sarah, you're on to the next component.
Yeah, thank you. Let's talk about a couple of reports. So next slide, please, Brian. Next. So just a highlight that our 2013 to 19 healthcare cost trends report was published this morning. It includes a whole bunch of stuff, and we are going to spend the next hour talking about that. So I'm going to move us on to the next slide. I also wanted to highlight that in July, Oregon's next annual hospital payment report was published. So this is an annual dashboard that includes the amounts that Oregon hospitals were paid by commercial insurance companies. It includes 116 inpatient and outpatient procedures, and the report includes the median price for each of those procedures in the commercial market. I want to call your attention to two things that are new in this year's report that are pretty exciting for us from a cost growth target perspective. So one is that for the first time, we now have 5-year trends in average payments, and we can see how those prices are changing over time. And then second is there is now a hospital comparison tool. So you can pick one or more hospitals or one hospital versus the statewide and look at a direct comparison side by side. And on the next screen, the next slide, this is just a quick snapshot of the 5-year trends. So you can look at the trends for average payments as well as cumulative growth in that 5-year period. This is just the roll up for inpatient and outpatient overall, but you can look at every single individual procedure of those 116 procedures and look at what the price trend has been. So there's a lot of really great data in here. I think as we try to start understanding cost drivers, this will be really helpful for us. And I just wanted to really highlight the great work from the hospital reporting program and another way that we can look at some commercial prices. And next, just a preview of what's coming out next in our team's body of work. We are continuing to work on a price versus utilization report. So as we talk about all of the data next about the cost growth trends and cost growth drivers, the next question that you are all going to ask me is, well, is it price? Is it utilization? Is it demographic changes in the population? This next report that we are working on will help answer that. So that's coming soon. And then we are also working on packaging up that 2018, 19, and 20 data. As I said before, we're not reporting this time period at the payer or provider organization level, only at the state and market level, but that will be coming from our data submissions, and we're working on that for this fall. So we're hoping to bring that back to you in a couple of months. Any questions about the hospital report or the reports in progress?
Okay, I'm not seeing any hands, so I'll just flag that they are all on the Oregon Health Authority's website. You can go there and take a look and click around and actually see the comparisons if you have those to take a look there. And just to note, as Sarah said, I think this is going to be a common trend as we go on the reporting and the data, is that it's almost all pre-2020. And so I think there should be a general understanding in this group that the impacts of COVID on our entire world and society are very real, and know that data lags behind reality. So we will catch up to that, and we'll start to incorporate that as we move forward, but we're not there yet. So.
All right. Are we ready to move on to starting to talk about the 2013 to 19 report? All right, heads are nodding. Okay, Brian, let's go ahead 2 slides, please. All right, so just to ground us in why we are looking at data and why we're going to be spending time with the report as part of today's committee meeting. This is our cost growth target program annual cycle where we measure, analyze, report, identify strategies for cost containment or cost mitigation, and then implement them. So as part of that measure and analyze, we want to look at spending to understand cost growth trends and cost growth drivers. We have to know where the problems are before we can start identifying those solutions. So next slide. One of the recommendations that came out of the Cost Growth Target Implementation Committee, your predecessor committee, was that we adopt a data use strategy, and that data use strategy would guide how we do the measurement and analysis. And I want to call your attention to the second bullet here that's highlighted, which is that we should be producing routine analyses that pinpoint leading opportunities to reduce healthcare spending by the state, payers, purchasers, and Oregonians in a manner that will not harm patients. So one of the first places to start with this type of analysis is, what are the historic trends? What are the historic cost drivers, and how does that differ by market? So we are going to look at those things by Medicaid, Medicare, and commercial markets, and to start getting that historic understanding of, as Felisa said, this is all pre-COVID, but what did the landscape in Oregon look like? What has been happening over the last few years, and how does that set us up for additional discussions and identification of potential strategies? Next. So the report that we're going to look at today has 3 chapters, and I know it just came out this morning, so you probably have not all read it in advance. That's okay. We're going to walk through it in detail today and highlight some of the key findings and some specific charts that we think are worth discussion. We're going to go section by section. So for each section, we're going to present the key findings. We're going to walk through some graphs, and then we're going to pause for some facilitated discussion. We have some prompt questions, but we think there's probably a lot that we can talk about here. So we'll go through each of these 3 chapters. The first chapter are the state and market level trends. Just overall, what does cost growth look like? Then we'll look at cost growth by service category, and we'll talk more about what we mean by service category and what goes into each of those categories. And then finally, we'll put some of the pieces together, and we'll look at, in each market, which of the service categories or what was the cost driver in each market. So it's not, it's looking at both the combination of total dollar amount as well as speed of the growth. So we'll put pieces together at the end. Next. Okay, I said all of those things. So next slide, let's talk real quick high level about the methodology, just for some grounding. So this is a claims-based report. The data we are using come from the All Payer All Claims database. It includes the plan paid amounts as well as the member paid cost sharing. So we're only looking at claims-based spending. We are not looking at non-claim spending. We're not looking at administrative spending, profits, a couple of other things. So just know that this is not a reflection of the total cost of care. This is not exactly how we will be measuring spending relative to the cost growth target in the future, but this really gives us a lot of detail and lets us drill down and understand what's going on despite that. These data are also not adjusted for inflation, nor are they risk adjusted. So just calling that out. And a note about the markets. So when we're talking about markets, we have 3 markets in this report: Medicare, Medicaid, and commercial. They are color-coded red, green, and orange consistently throughout. When we're talking about Medicare, that includes Medicare Advantage as well as traditional Medicare or Medicare fee-for-service. When we're talking about Medicaid, that includes the coordinated care organization population as well as open card or Medicaid fee-for-service. And then on the commercial side, we have the fully insured commercial market, the PEB and OEB public plans, as well as some self-insured plans that submit data on a voluntary basis. So it's not quite the full commercial market, but it's a lot of it. Any questions about the methodology or the inclusion here?
Sorry. Here we go. Could you give a sense of how much of the self-insured you think is captured? I mean, do you think, are you capturing 70% or 50% or?
Oh, I am going to possibly have to respond to that in the chat after I consult with the team. I don't know that off the top of my head, but I do want to say that I think we have more than 90% of the lives in Oregon represented in the APAC data. So let me get back to you on that. Oh, I don't want to be inaccurate.
Thank you. That's great. Actually, that's kind of gives me a sense of the idea. Okay, I appreciate it. Sorry, I couldn't get my hand raised.
Okay, let's keep going then. Next slide, please. All right, cost growth trends. I am going to hand it to my team member, Zachary Goldman, in a second, and he is going to walk through the data. But next slide, we wanted to give you the key findings for each section, just sort of top line before we walk through the data. And we had some really great discussion with some of our counterparts in other states and thinking about punchy communications. And so we have this, if we were tweeting our key findings, what would we be saying about them? We are not tweeting our key findings right now, but we repackaged our key findings, our executive summary, into what we think would be a pretty good tweets for a state agency. And want to summarize those for you here. So key findings for the first section, cost trends. Between 2013 and 2019, healthcare costs in Oregon grew at an average of 6.9% annually, which is faster than the national average, 4%. And again, putting that in context, the cost growth target did not apply during this period, but if it did, that cost growth target value is 3.4%. Between 2013 and 2019, increases in healthcare costs in Oregon grew faster than inflation and medical inflation, and far outpaced increases in income and average wages. And finally, between 2013 and 2019, Medicare per person healthcare costs in Oregon grew 58%, commercial costs grew 45%, and Medicaid costs grew the least at 32%. And that's cumulative growth rather than year over year average annual growth. We're going to talk about both of those types of growth in this section. All right, Zachary, I hand it over to you.
All right, hi everyone. Let's go to the next slide, please. Okay, so here we put a finer point on some of the points that Sarah was making. So on the left-hand side, we have the Oregon story and then the national story. So the Oregon is the dark blue. Every year, so in 2014, cost grew 7.6%, little volatility, and then by 2019, 4.4%. Notably, every year's growth is larger than the national average growth of somewhere between 3.8 to 4.3%. So our costs are growing faster compared to the national story. If we look at the dollar amounts, that's on the right-hand side. As a dollar amount, it's actually less, so it's less costly. We were at $4,500 in 2013 compared to about $9,000 nationally, and as of 2019, almost $7,000 compared to just over $11,000. So fewer dollars, but faster growth. So eventually we catch up, assuming this current trend. Let me pause there. Lawrence, please.
Yeah, I'm sorry if I'm asking too many questions in the middle. Just please tell me. On the tweets, I was struck by the right-hand side as much as the left-hand side, and that Oregon's cost is so much less than the national cost. And another way of thinking about it is, while the percentage growth is higher, the dollar growth in Oregon over this time period, if I'm subtracting right, went up $2,207 per person per year, while the national went up $2,422. So went up actually more. So part of the reason Oregon's growth is higher is we're starting from such a lower base. And so a smaller dollar amount is a larger percentage. So I just thought that the right-hand chart, both charts are really interesting and really important, but the right hand really gives a lot of flavor to the left hand.
Yep, that is all accurate, for sure. Okay, let's move on to the next. Oh, please, Gil.
Yeah, I was curious if we have sort of normalized a standard benefit package across when we look at these national trends. It is what is offered in Oregon consistent with other benefit packages across the states, or are there markedly differences in the data?
Yeah, that's a great point. So there's a couple dynamics at play. One is changes that happen both to Oregon and to other states simultaneously, notably 2014, the implementation of the Affordable Care Act that happened across the board. With the exception of those states that didn't expand Medicaid, it looked different for those states compared to those states that did expand Medicaid in 14. And Gil, to your other point, even within Oregon, there have been benefit changes, even within Medicaid itself between 2013 and 2019. There have been changes to the commercial market in terms of what benefits are mandated. So yes, all that kind of noise is built into some of these changes. And that's true for the national story as well. Yeah, Melissa, and then we'll go to Peter.
Yeah, do we understand generally in Oregon, at least on the commercial side, and it probably goes for some of the Medicare Advantage plans, around the proportion that have high out-of-pocket deductibles and how that compares to other states or nationally? I think that when I think about consumers and I think about their concerns about out-of-pocket expense, both on the premium side, but also from, kind of what that high deductible component is, do we have a sense where Oregon sits overall compared to other states and those high deductible plans?
Mm-hmm. Yeah, great question. So we have done some work, and University of Pennsylvania, I believe, has done some work on a state-by-state basis, and found that Oregon had relatively high deductibles compared to other states. We can dig up that analysis too and send that around. But that is for sure a factor, right? If a state has very low deductibles, that may influence its utilization patterns compared to a neighboring state that has really high deductibles. Yeah, so that is a factor.
So can I just jump in here, Zachary, before we go to Peter, because I saw Sarah's hand slightly go up. And so Sarah, if you have something to add, and then Pat, I saw you add your hand and take your hand down. So if you have something to add, jump back in, and then Peter will come back to you. Okay, so Pat's waving me off. Sarah, are you waving me off, or do you have something to add?
Just going to remind folks that we put out a report in April that looks at the impacts of spending on consumers, and that does include quite a bit of data on the premiums and the deductibles. And so we can put that link in the chat for folks that maybe haven't looked at that.
Okay, Peter, you're back on. Are you?
You bet. Thank you. I just wanted to follow up on Lawrence's comment and think a little bit about both the past trends in pharmacy as they apply to sort of the national average versus Oregon's managed care. Over the years, we've always had a lower cost of care. Medical used to predominate a much greater percentage of the cost. Pharmacy has probably more than doubled as a percentage of the overall cost. We pay a national pharmacy rate, not an Oregon pharmacy rate. And as we think about cell and gene therapies that are really going to drive the percentage of spend through pharmacy in the future, that's going to look more like that national number. So as we start to think about these percentages, it's going to be hard to manage within a percentage coming off a small base when we're playing with national pharmacy costs. It's just something we should think about.
Thanks for that, Peter. And that's a perfect segue to when we get to chapter 3, we're going to dig into a little bit more of by the service categories. And so we can talk a little bit about the pharmaceutical spend. Yeah, very, very prescient.
So I'm also going to just put a quick hold because Zach has a handful of additional slides that go through some of these trends. And then actually, we do have a series of questions that we're going to be jumping into at the end. So I want to encourage people to skip ahead to slide 32 really quick while Zach goes through the rest of these slides so that we, not you, Zach, people on the call. You don't skip ahead, Zach. You take your time. But people on the call, skip ahead to slide 32. Look at the questions as Zach goes through these slides because we're going to have a more robust discussion. Stefan, do you have something you want to add?
Yeah, no, I think I should look for a slide. So I just want to add that, like, these costs, they reflect a lot of things. Like one thing is demographics, and one thing is sort of but what is the income level in the state? And the other thing, it's like we don't show necessary prices. So I just want to make sure we're clear on the difference. And it's like, so I think if I remember correctly, I tried to find the source, but like Oregon's prices are relatively high, but the utilization is relatively low, and so it comes down to like these lower below average healthcare costs. So I think there's some nuances here in integrating.
Yeah, great points. Yeah, I mean, these top level findings are really combining so many dynamics at play, right? As Stefan's pointing out, it's both utilization and underlying price. As others have pointed out, there are changes of benefit design, whether or not deductibles are changing and influencing consumer behavior. So many dynamics at play in these top level findings. Well, let's jump to the next one. These are great. These are you all are so engaged and so familiar with a lot of these concepts, and are super knowledgeable. So let's talk about annual per person healthcare cost growth relative to kind of an imaginary 3.4%. As Sarah mentioned, that cost growth target was not in play from 2014 to 2019 for all these markets, but if they were, this is what it would have looked like, right? Ranged from 7.6 to 4.4. Or some high years, some low years, but that's been the trend. Let's go to the next slide. Okay, well, compared to what? So let's contextualize this a bit more. So the top blue line here is per person healthcare costs, all markets combined, cumulative, indexed on 2013. So 2013 is 0, and then we grow from there. If we compare that to per person income in the state and wages in the state, it really kind of dwarfs those two indices, 49% compared to almost 32% compared to almost 22%. So the takeaway, healthcare costs on a per person basis are growing faster than both income and wages. Let's go to the next one, please. Same idea, but let's compare to inflation. So medical inflation ranging from that time cumulatively was 17%. Medical inflation usually trends higher than consumer price index inflation. So we put them both up here. So that was 9.7. Again, per person healthcare costs just really dwarfing those two indices. Let's go to the next one. So here's where we get a little more granular, and this is where we start to get fun, right? Because we can look at each market. So statewide is the blue. The top highest one is Medicare. Orange is commercial, and the lowest one is Medicaid at green. And as I believe it was Peter mentioned, or maybe it was Lawrence, talking about, percentages on a large number means something different with that same percentage on a smaller number. So for sure that's a dynamic at play here, particularly when you're looking at Medicare at such a high dollar amount compared to Medicaid at such a low dollar amount. But here's kind of the overall trend. And then in 2019, you can really see the difference here, 11,000 for a Medicare per person spend compared to 3,600 for Medicaid. Now, there's a lot at play here. Health risk, the cohorts that are covered by these different markets, there's a lot going on. some of this is maybe unsurprising. Let's go to the next one, please. So what if we index it? Index it to 2013, same dollar amounts, really, same data. But here we see Medicaid having the lowest cumulative growth at 32 and the highest for Medicare at 58, and then commercials in the middle at 45%. It all rolls up into kind of a weighted average of 49%. Let's go to the next slide, please. Okay, well, let's look at the annual growth. So not cumulative, but annual. So we can see kind of the spikes, peaks, and valleys. So a couple of interesting things here that you can see right out the gate. The orange commercial line, huge spike in 2014, with a kind of an inverse for the green Medicaid line going from 13 to 14. So there's a dip in spending for Medicaid, but a spike in spending for commercial. 2014, as you all know, the Affordable Care Act was fully implemented. And then in later years, there's kind of an interesting trend, particularly in Medicaid, where you have relatively high annual growth rates in 17 and 18. And this is when the Medicaid redeterminations were occurring, as well as some other benefit expansions that were happening in the Medicaid program. We can talk about that in this presentation, and the report really goes into detail about what those changes were. For Medicare, this is really interesting. There's a big spike in kind of 2015, and then it trails down. So that's just kind of an interesting piece of the data there. Let's go to the next slide. So same idea, but let's look at member months, right? Instead of price, let's look at enrollments. Let's start with the top line here, the green one. So this is Medicaid. Huge expansion of Medicaid, as we all know, 2014, again, the ACA. And then starting in 2015, there's actually a dip in 16, and then an even greater dip in 17, and then it kind of plateaus. This is the fallout from a Supreme Court decision called the Gobet case, or frequently called the Gobet case, which functionally resulted in fewer individuals with commercial self-insured coverage being submitted into APAC. Sarah mentioned before that we've done some analysis because we do get a lot of voluntary submissions to our all payroll claims database. So we do capture about 90+% of Oregon residents, but there's still a dip there from 2015, 2016. The Medicaid line, excuse me, the Medicare red line is pretty flat in terms of cumulative growth. There is a kind of a downward trend of the orange line that you'll see there. And that's, oh, I'm sorry, I was misspeaking. Let me back up. The Gobet case, look at the orange line for the Gobet case drop, because that's where we're losing folks on commercial side. Sorry, the Medicaid drop in 17 and 18, that's the redeterminations. Sorry, I got my colors mixed up. So just to summarize, yeah, that top line, Medicaid green line, that's the redeterminations in 17 and 18. But then the kind of the cumulative drop in the orange line, that's the Gobet case for commercial. Let's go to the next slide. Okay, so now I'm going to kick it back to either Sarah or Felisa to talk about what's interesting.
Okay, so now's not the time to stare at us silently. I know you all were thinking various things throughout this. And so let's start. I think, you know, Zachary's still on, obviously a lot of experts on this call. So if there are additional questions, please jump in with those too that can be answered. So was there anything that was surprising? Let's start with that. Yeah, Gil.
Yeah, well, I was struck with the increase in Medicaid costs with perhaps the explanation that coincided with increased redeterminations, and so I'm curious as to why that is. I mean, I have some thoughts about why that might be as people churn, but is there any conclusions that we've been able to draw from that?
Yeah, I can chime in with that. Great question. So the relationship there is when we were going through redeterminations in 17 and 18, what we found was as folks were having to go through the enrollment process again, we were redetermining if they were eligible. Some folks just ignore the mail and the questionnaire that they have to complete, or call this number to verify this information, that kind of thing. Some folks ignore that, other folks don't. But there's a strong relationship between the folks that have current healthcare needs and the likelihood that they're going to go through the steps that is required to re-enroll. So in effect, the redetermination process itself had a noticeable and quantifiable change on the underlying kind of risk, health risk of the Medicaid population. So in other words, after redeterminations, we had a riskier cohort of members, and those folks had higher healthcare needs and subsequently higher costs.
Kadesh?
Yeah, Zachary, maybe this question for you, but what surprised me the most is the difference in Oregon, actually the absolute cost and national, it's 40%. And that's a big number. 40% of, if we were operating at a national level, our cost would be 40% more here in Oregon. So it just to me, it requires some couple things. One is that for you, is the data source the same? Are you using different data sources for Oregon, like claims data and maybe a different data source? So, that if that's the same data source, I think one thing we got to look at is what is the driving force? Is it controllable or non-controllable, right? One is line of business. If we have a greater share of Medicare members in Oregon, then obviously, you're going to have more usage. They just use 3-4 times more than commercial. So it'd be good to look at lines of business. And if nothing, then I think you look at some neighboring states. So you remove the geographical, differences between, the East Coast and West Coast. And, things like maybe we have a higher utilization of, mental health services. Like I do know from my data world that those types of utilizations are higher in Oregon than compared to California states. So, and then the other thing would be good to look at is by going to the service category. What is the service category? Inpatient, outpatient? Are we investing in some models like primary care at home type models that might have a bigger expense trend, but there is a savings in other more expensive tertiary settings? So I mean, those are my comments that what surprised me.
Let's go to Lawrence, and then I would definitely like to hear from some of the consumers on the call about the data around. So maybe Greg, if you want to think about if you have any comments, or Shannon or other folks who sort of are on the spending side of this as well, the purchaser side. Lawrence, and then Teresa. Lawrence, you're on mute.
Sorry, yes, I think after 2.5 years. On the first question, what surprised me most was page 28, the Medicare line, looking at dollar increases, where the dollar increases are pretty steady, constant on the other payers. There's this very large increase from 14 to 16 on the Medicare. And I'm wondering if you had there was something that was going on either from a federal perspective or the inclusion of pharmacy or something else that was happening there.
Yeah, that's something that I think we're going to look more into. As we'll see, pharmacy is really driving the ship there for Medicare cost growth. We'll get to that. So very well could be a couple blockbuster drugs came out that year, and they were particularly utilized by Medicare individuals. So yeah, more analysis needed as to the rationale there.
Blockbuster drugs. Okay, Teresa.
I was focusing on a little bit of the same thing. I was looking at slide 30 and noticing how Medicare seemed the most volatile in terms of growth per person, and really peaked in 2015 and then coming down since. But it just seems like there's things going on in Medicare that would be good to understand. And then also, I don't know if we've seen it yet, you probably have it somewhere, is how much in terms of total cost, how much is is made up by Medicare versus Medicaid versus commercial. Like I know we look at each of them individually, but how much are each of them weighted when you multiply it out by all the member months? So curious about that as well.
Yeah, great question. I don't think we have a slide for that necessarily, but we could put something together. And the short version would be to look at the dollar amounts. Well, no, I guess we wouldn't have it because you don't have the underlying people. So we'd have to put that together, which we can do.
Great, thanks.
There's a lot of data requests. I'm looking at, again, at, Morgan, do you have any thoughts on these trends or compared to what you're seeing on the private side?
Yeah, the commercial market decline starting in 2014 was really, really interesting, and just kind of, I guess, wondering or curious, how are those people being displaced in other places in the market? I mean, that's a pretty stark difference compared to all the other ones that we're looking at on slide 31.
And is that the on 31 where we're showing the enrollment there?
Yeah, it just, from 2014 to 2019, it was the biggest difference amongst Medicaid, Medicare of one decline and just sheer numbers. So we'd be curious to see if we have data on where those folks are being displaced.
Yeah. I mean, just anecdotally, a lot of those folks still have ERISA self-insured coverage. It's just not reported to APAC anymore. So they're probably still there, but just not in our data. Although we do get a lot of self-insured voluntary data. So it's a mixed bag and hard to tease it out.
I guess following up on that, do we have data, or is it easily accessible of breaking down the percentage in Oregon that is on an ERISA plan? So just so we can comparatively look like our population. So if we're looking at this, what percentage of the Oregon population is this, and what percentage are we not able to capture because they're on a self-funded plan?
So I think Zach was going to bring that info back, and then Andrew, is there anything you want to jump in here on since you're on the insurance commissioner?
Thanks. We do have that data on the commercial market, across markets, kind of where people are, so we could kind of see what that is. I can add that I think between 2016 and present, there has been a decline in the commercial market. A couple percent on the individual market. We can share all. We've got all those specific numbers. We can share what those are, kind of year and over years.
Well, I'm going to just wrap this portion up because we do have the Oregon cost trends by service category is the next. I'm expecting a similarly robust discussion in that area as well. And so what I'd like to do just quickly is I know that there's a long list of data that Zachary and team is going to bring back. And so it seems to me, I'll touch base with Sarah after this, that we kind of should have a little section of this on our next agenda as well to go through, because I don't think, frankly, we shouldn't get tired of ever looking at costs, because that's what we're here to do. And I know by looking at the very intrigued faces and the leaning in and out of computers that I'm seeing that we won't get tired of looking at costs. So we'll just put this on the next agenda item to bring back some of those reports. Does that sound good, Sarah? Okay, so Lawrence and Peter, if you have something burning, let's hear it now. Otherwise, I'm going to kick us to the next section. Peter.
It's not burning, but it's just around this Oregon trends to change after 219. Obviously the COVID trends are going to throw a wrench in any percentages, underutilization in certain lines of business in 2020, and then picking some of that up in 2021 and 2022. I wanted to follow up on something that Zach was talking about, though, which is with the suspension of redetermination during COVID, you're going to see obviously a big growth in the Medicaid business. But as we redetermine that, you're going to have a selection bias against people utilizing care and not utilizing care that may very well have a big impact with that expanded population on trend numbers in Medicaid. And it's just something that we should be aware of.
Great. I think just a quick summary, I think for those not following Medicaid as tightly as everyone on this call, is that during COVID-19, the federal government suspended Medicaid redeterminations. And so we haven't done Medicaid redeterminations in almost 3 years. And that is becoming due, which means a lot of people could cycle off the Medicaid program when we redetermine their income and eligibility. That's what Peter is talking about. And so it's a very hot topic because it's almost 1 million people. So Mary Beth?
Yeah, I know you want to wrap this up, so I'll keep this quick, but I did want to just comment what Peter had said about we'll see changes in 2020 data because of COVID. That's part of the reason why I really appreciate seeing both the average numbers, but also the annual data and seeing it broken down both ways, because I think it's really important to see those trends over time, not just the holistic view, because digging down into those numbers really can, I think, show a better picture sometimes. So thanks. And I think that we should continue doing that as we go forward with 2020 and beyond.
Okay, now we're going to roll into by service category. Spicy. Go. Who's up for the service? Is that you, Zach? Are you keeping on rolling?
I'm going to tee it up for Zachary again. And I think given time and how robust the discussion is, I'm going to propose that we cover chapters 2 and 3 together and then open for discussion about both of them. So slight modification to the plan because you're so engaged. And I'm really loving the leaning in and like peering at the screen. This is exactly what we want. Totally agree that we can bring more data back. And I want to just reiterate something Felisa said at the beginning of this agenda item, which was these are high level trends. This is the start of the conversation. And I think it's probably going to start feeling really frustrating when we start saying, oh yeah, we can bring that back, or we haven't gotten to looking at that yet, or oh, that's a level of detail that we haven't dug into. And I think part of the reason for this committee is to help steer our additional analyses and to help us prioritize and understand where we should be doing that additional work. So recognizing that this presentation and this report is very high level, it's older data, it's the historic trends, and you are absolutely raising costs. I already have 2 pages of notes of like scribbled follow-up requests of other things to look at. So this is exactly what we want, and just recognizing that this is going to continue to be high level for the next half an hour. So, okay, next slide. Actually, Brian, let's go ahead 2 slides, one more. So the next section of the report talks about cost growth broken down by service category. And these are pretty standard service categories if you're familiar with service category analysis. And if you're not, I want to talk about just what we're talking about really briefly here. So we are able to group all of the costs and all of the claims into 6 different categories. So we have inpatient care, so that's services that are happening in a hospital. We have professional services, which are services that are related to diagnosing and treating medical conditions. We have outpatient care, which are services that happen in an outpatient setting, so going to the doctor's office without an inpatient stay or a hospitalization. We have pharmacy costs. So these are retail pharmacy costs, not medical pharmacy costs. So this is when you go pick up a prescription, not when you get a drug at the doctor's office and they administer it on site. We have emergency department costs. So that's a visit to the ED. If a visit to the emergency department turns into a hospital admission, all of those costs and dollars are counted as inpatient care. And then finally, we have other. So other is a little bit of a catch-all, and it has the remainder of the dollars that could not be categorized in those other 5 categories. So that includes things like ambulance rides, lab services, and anything else just that doesn't fall into those major buckets. When you're talking about service categories, sometimes there can be a lot of overlap between what gets billed as a professional service versus outpatient service. Sometimes that's really similar in terms of what it actually is from a patient perspective, but it's how we're categorizing the claims and how the billing happens. So that was just a very, very quick and dirty on service categories. Now, if we can go back 1 slide, Brian, to my tweetable findings about looking at the data by service category. So we have a couple different ways that we can break down the service category data. So if we look at the total per person healthcare costs in Oregon in 2019, that was that $6,700 per person. Most of those dollars are coming from inpatient hospital services, $1,799 per person, and professional services like doctor's visits, so $1,695. So the sort of big ticket categories are inpatient hospital and professional services. But if we're looking at growth and how those categories are changing over time, Between 2013 and 2019, per person pharmacy costs grew cumulatively by 116%, more than any other service category in Oregon. Per person pharmacy costs were $1,365 in 2019. If we look at the 4 largest service categories, inpatient, professional, outpatient, and pharmacy, all of them grew faster than 3.4% each year. And per person pharmacy costs grew the most, almost 14% each year. So our headline finding for this report was mostly driven by pharmacy costs, and we're going to start unpacking exactly what that looked like in the markets. Okay, Zachary.
Now let's skip a couple slides ahead, please, Brian. Great. So here we see on the left-hand side, we see the dollar amount of these different service categories and then how much they grew from 2013 to 2019. So as Sarah mentioned, inpatient is the biggest service category, about $1,500 in 2013, and it went up to almost $1,800 in 2019. But what you can tell here is that not only the size of the relative service category in terms of dollars, but also its rough slope from 2013 to 2019. So the red pharmacy line, for example, has a pretty steep slope, steeper than the outpatient, for example, and actually became the 3rd largest category in 2019, as opposed to the 4th largest category in 2013. So you can see kind of the dynamics at play and which service categories are both large, but also which ones are growing faster or slower than others. The 2 bottom ones, other and emergency department, these are relatively low dollar values compared to the other big ones. So that's why we grade them out here. Other actually went down a bit. That one's the catch-all. ED went up a little bit. Yeah. Let's go to the next one. Same data, just different visualization. This is more of a kind of a stacked area chart. The total, the black line here, is going from 4,500 to 6,700. But you can see the composition of those dollar amounts. So again, inpatient and professional services are the biggest blocks. Outpatient is relatively large. Pharmacy gets larger as it gets to 2019, and the little green emergency department is relatively small. But you can see kind of they're all pretty much growing, but some are growing faster than others. Let's go to the next one. Oh, let me pause here. Jeremy, go ahead, please.
Sorry to chime in here. I think it's important because I think everybody's got sticker shock around the pharmacy to know that this is our all payer all claims data, and we receive basically gross pharmacy costs before rebates and the all payer claims data. When we get to the new cost trends report, we'll be getting total rebate dollar amounts from the carriers, so we can offset that. But right now we don't have that, and so that makes up a lot of pharmacy spend, that rebate amount. And so just note that this could be skewed. It may not be, but it could be skewed if rebates have been growing faster than or the same rate of the overall gross spend.
Yeah, great call out. Thank you for that, Jeremy. We dedicate some space in the report to that particular caveat, and I'm glad you mentioned it today. So here we can see, oh, Lawrence, go ahead.
Oh, sorry, just before Lawrence jumps in, we have a quick question in the chat from Gil. Is primary care captured in outpatient costs or professional services?
So they would mostly, so the service categories are really based on the location of service, the service location. So they're mostly going to be, they'll be split actually, now that I think about it. So the kind of providers reimbursement for the provider section will be captured in professional, but if there are other costs, they can be borne in outpatient. So if there's different lab costs or something like that, that could be outpatient. So this isn't the best way to look at primary care spending growth. We'd have to do a different analysis for that.
And then just for folks, I know we're trying to look at the presentation as well as any other documents we have up, but I have asked Pat to do quick summaries of things in the chat of things that we might not all collectively understand. So for example, pharmacy rebates and what that means and why did the issue that Jeremy, redetermination, et cetera. So Lawrence?
This is a sort of question with a supposition. Because pharmacy is defined as retail drugs and does not include physician or I presume clinic administered medication, is there a fair amount of pharmacy growth in the outpatient and professional services bars also? And is there any way you can tease that out?
Yeah, so that would be an additional analysis. There are ways to tease that out. It's fairly complicated, but there are ways to look at drugs in both an inpatient setting, an outpatient setting, and anywhere else. But it's specifically, what we try to do is wall off retail, because that's reasonably definable in a simple sense. And subsequent analyses can dive into deeper.
And I want to add that that is on our wish list of future analyses, is to dig more into retail versus medical pharmacy. Some of the other cost growth target states are leading some work on this, and we're partnering with Andrew's team at DCBS from the Prescription Drug Price Transparency Program to understand where we can do some complementary analysis. So I suspect there'll be a lot more coming on pharmacy, but please keep putting your requests in the queue.
Yeah, great. So here we have each service category and their growth from 2013 to 2019. So just as a reference point, the black one with the dotted line, that's a 3.4%. Inpatient grew just over that at 3.5%. Outpatient almost 7.5%. Professional 8%. And these are annual averages. And then pharmacy almost 14% annually. So it doesn't take too many years to talk about compounding effects here. Let's go to the next slide. And let me pause here. Our ambulatory service centers included an outpatient. Yes, ASCs would be an outpatient. If they are kind of standalone, yeah, it would be. So let's dig into each service category. So let's look only at professional services. So this is only professional services service category. The red line is Medicare, orange line is commercial, green line is Medicaid. We have the dollar amounts on the left, so you can see approximately what the per person spending on professional services was, and then the overall growth. The percentages on the right is that cumulative growth from 13 to 19. So Medicare started at about $1,500, went up to $2,300, and so that's a 57% growth. Obviously, those dollar amounts are higher than Medicaid, which started, $600, went up to $900 or so, and had a growth of 42%. Let's go to the next service category. So here we have pharmacy, and we're just highlighting some of the main interesting service categories. We have them all in the report, but we just wanted to highlight a few today, or a couple today. So pharmacy is particularly interesting to me because given all the caveats that we mentioned and what Jeremy brought in, that this does not reflect rebates, but clearly there's some diverging lines here, namely the Medicare line in the red started sub $1,000, so less than $1,000, but by 2019 it was about $2,200–$2,300. That's 185% cumulative growth. Commercial, we're looking at almost 93%, and Medicaid at 79%. What you'll see, and this is a really common trend, that Medicare is the highest, Medicaid is the lowest in terms of dollars. The growths vary, but by and large, Medicaid growth is lower than commercial. And let's go to the next one, please. Okay, so those were the two kind of particularly interesting service categories that we wanted to highlight. I think we're going to keep chugging along here, and then we'll come back and discuss both what we just talked about and then some of the deeper cost driver analysis that we're going to get to now. So let's jump to the next slide, and then the one after. Sarah, did you want to tee up these? Keep going. Okay. So here, now we're talking about what's driving the growth itself. So that's different than what we've looked at thus far, right? Which is overall trend and then by service category. Well, when we look at overall growth within a market, which service categories are more responsible for that overall growth of the market? So commercial cost growth was driven mostly by professional services. Those services increased from $942 per person to just over $1,600. In terms of Medicare, in the Medicare market, what drove most of the cost growth there was pharmacy. So it increased from about $800 per person in 2013 to $2,300, almost $2,300 per person. That's just over 6 years. In the Medicaid market, there's kind of a twofold driver. Two entities are in the driver's seat here. Pharmacy was pretty big, increased 79% in 6 years, but professional services also increased a fair amount, 42%. But let's look at some of these graphs here. Before going that to Nick.
Thank you. Quick question about the slide. The way you are presenting the information changed for the third one, and so just for consistency, it'd be nice to see things presented the same way. I agree with Gil that it was really important to understand more about professional services, because it sounds like a lot of things get lumped in there that it's not easy to understand what's in there. It'd be nice to see more segmentation.
Yep. Great, that's great feedback. Let's go to the next slide. Okay, so I'm going to present you three charts here. They're a little complicated because they convey a lot of information simultaneously. So let me just orient you to what you're going to look at. On the left side, on the y-axis, the up and down, we're talking about the per person cost in 2019 dollars. So the higher it is on the left and on the up and down, the higher dollar amount we're talking about for the 2019 price per person or cost per person. On the bottom, the x-axis, the horizontal axis, we're talking about cumulative growth from 2013 to 2019. So the further on the right it is, the more aggressively it grew. So for example, if there's a little dot way on the left, but really high up, that means it didn't grow very much, but it had a high dollar amount in 2019. Conversely, if you had a little bubble all the way on the right, but pretty low down, low dollar amount, but high growth, right? So that's what we're talking about, growth and dollar amount. The bubble size, the size of the bubble and the size of the color size is, the larger the bubble, the more responsible it is for the total per person cost growth. Now, obviously, that's a function of kind of the price and the cumulative growth, but it helps paint a picture as to, well, why is the Medicare market growing so much? Why is the commercial market growing so much? Which service category is responsible for that? Okay, so now we're oriented. Let's dive in. Let's go to the next slide. And we're starting with commercial. So commercial, professional services, the kind of blue aqua color, had the highest per person cost. It's highest up on the graph at $1,657. Pharmacy, the red maroon color, had the largest percent growth because it's furthest on the right. So it grew 93% cumulatively. And in terms of bubble size, we're really looking at professional services, the largest bubble, followed by pharmacy, followed by outpatient. So it's those three service categories that are really driving the overall cost growth of the commercial market. Let's go to the next one. What I find most interesting is how these vary and how different these are. So let's look at Medicaid. So in Medicaid, inpatient grew the highest. Inpatient had the highest per person cost at $1,350. It's the highest bubble in the up and down. Yet it didn't really grow very much at all. It grew 3% from 13 to 19. So that's why it's pretty much on that axis and it's not further to the right. The other category on the bottom right, that grew the most, but is only $138. So it's not much dollar amount, but it actually grew the most as a service category. But what you take away from this is pharmacy and professional are clearly the two biggest bubbles here. So those are really in the driver's seat for the market in terms of overall growth. Felisa, please.
So I think my question here is, which of these prices do we set? So Medicaid is a sort of a different bailiwick here, and we set prices in Medicaid. So which of these prices do we set versus which are negotiated prices?
So because these are the prices that providers are receiving, either from CCOs or from us, in the Medicaid market, this does include open card. So in that sense, the state is setting those rates, actively. But because the state doesn't necessarily set CCO to provider rates, then I'd argue that those aren't set. Now, the dynamic may be different than, say, a commercial insurance company and a hospital as compared to a CCO in that same hospital, but I think it's fair to say the state does not set that rate that the CCO is going to pay to the hospital. Yeah, so Medicaid and commercial look very different. Let's look at Medicare. Let's go to the next slide. And different even still. So in the Medicare market, inpatient is the highest dollar amount. So inpatient had the highest cost per person in 2019, over $3,000. Interestingly, it had the lowest growth at 25% compared to the other service categories. Pharmacy is its own planet off on its own universe. Pharmacy is really big, clearly the biggest cost driver overall per person cost growth in Medicare, grew at 185%. So that's clearly driving the ship there. Outpatient, professional, and inpatient are relatively the same bubble size, at least they're similar. So in terms of who's second, what service category is second most driving the overall cost growth, it's probably a close three-way tie between those two. Oh, excuse me, between those three. And let's go to the next slide. So here we want to, yeah, Sarah, do you have this one?
I can. You want to keep going? Keep going.
Okay, I'll go for it. So we've been paying close attention to other states that are doing similar work. Connecticut has a cost growth target. They call it cost growth benchmark program. They did similar analysis for 2018 to 2019. So we looked at more years than that, as we've talked about, but they looked at just 18 to 19. In their analysis, their top three drivers in the commercial market were hospital inpatient, hospital outpatient, and retail pharmacy. So we looked at our trend for the same time period just to get a sense of, are we in the same ballpark? Are we different? How different are we? Let's go to the next slide. So again, this is just a 1-year growth, 18 to 19. Per person growth for us, 5.3% in the commercial market. Connecticut had over 6%. The dollar amounts are pretty different. We had 5,000, they had over 7,000. And our service category growth is fairly different, right? We had actually a contraction of growth in the commercial market for inpatient, whereas theirs grew by over 9%. For hospital outpatient, we had over 8%. They had 7.5%. Okay, that's reasonably close. For retail pharmacy, we had over 6%. They had 4%. Close, but maybe a little further away. So all that to say, these are pretty different. The dynamics at play in Connecticut are likely different than what we're facing. I think this is probably a use case for why state all payroll claims databases are a good thing. And this is why we're not using national data, because we need our own data. Any other points to cover on this one, Sarah?
Yeah, I think we just really wanted to highlight the importance of looking at our own data, and even again, that this is high level analysis. I think we've been following other states and seeing other states looking at their cost drivers and starting to think about what their strategies or next step policies would be, and not been exactly sure that would be what we would find in Oregon. And I think this is just one quick comparison, one quick example that our cost drivers are different. And as we go into the next conversation, and as we continue to look at these data over coming months together, and we talk about what our strategies or opportunities might be, they are different here. Our market is different. Our dynamics are different. Our level of consolidation is different. And that all really just speaks to the importance of looking at our own specific data and understanding our own specific drivers. That was the point we wanted to make.
Okay, I think just quickly, so before we actually jump into the discussion on this, I want to just take a quick pause to make sure that we're not missing anybody for public comment. Since we did say public comment was at 3:30, I don't want somebody to be waiting patiently for us. We want to give that quick opportunity.
No one has indicated in the chat or over email that they want to give public comment.
Okay. All right. If you do decide that you want to give public comment in the chat, please jump in and put that in the chat so we can come back to it. And I will stop our discussion to make sure that we have time for that. So, but let's kick it off to the discussion. Charles Galea is in the chat with his public comment. So how big a deal are crossover claims, dual eligible impacts of subcapitation? Zachary?
Yeah, I can address this. Hey, Charles, it's been a while. Good to hear from you. So yeah, dual eligible folks are in here. It's based on which market paid for what service. So there's going to be some noise there because a given person who's eligible for both, they have some services that may be covered by Medicare. And if they're not, then those services will be covered by Medicaid. So that is reflected in these data. Impacts of subcapitation for any kind of zero paid claim. I'm going to get wonky for just 10 seconds. Sometimes there are situations in which a claim comes over, but there's actually no dollar amount. And sometimes the reason is that provider has been paid on a capitated basis. So that the CCO or the commercial carrier has just paid that provider a lump of money that's not predicated on a particular claim. We've done no imputation for those zero paid claims. We've just taken them as they are. So that would be kind of additional analyses to impute that and kind of deal with the level of subcapitation that exists. Okay, let's go to the next slide.
So I think we're going to.
So here's where we open it up.
Yeah, I think we're going to take this discussion based on the last two groupings. So we sort of had the discussion about the why am I blanking on words? Service category area. Thank you. It's going to come to me in just a minute. So the service category areas as well as the cost drivers. So are there thoughts or surprises that people saw in either one of those? Melissa?
Yeah, I think, I mean, a couple of things, and Sarah's pointed this out in conversations on the professional component, and to Gil's point, it'd be helpful as we've, thoughtfully tried to expand primary care and primary care access in the state, that, how much of a driver is that? And that could be a good thing, right? It is a good thing, I think, if more people are accessing primary care and spending. The outpatient growth is interesting to me, and I think it also could be something that we could view as something positive. When I think about technology advancing, and if someone's not going in for a biopsy now, but instead they're having imaging, less invasive for diagnostic purposes, that probably could be a good thing. So there's components in there that I think would be helpful to understand. And I think we've seen even more of that with COVID, right? People not coming into the hospital for care, but instead looking for other ways for diagnoses. And just therapeutic changes as far as that's concerned. I think the last thing for me that would be helpful to think about on the drivers is really around behavioral health, right? And across all services, right? And I think that was brought up before as well, but how has that changed? And how is that different in other states? And just when I look at the different service locations, I forget the term on that, the cost may go up, but how much of that is a utilization component, right? So anyway, it's great information, and I think it's a good discussion, but those were just some of my thoughts on this. I don't even know what to say about the pharmacy component. I mean, I think everyone struggles with that.
Thank you. So I just want to give a chance to Sarah or Zachary to answer any of the thoughts that Melissa had, or sort of the key questions she had. If not, we can kick it to later and bring those back, but.
Just one comment to reiterate what I said earlier, that we absolutely know that the next question, we knew someone was going to say it, so thank you, Melissa, for saying it. The next question is, how much of this is price versus utilization? And that is the next layer of this analysis. So I don't know if we'll bring that back to you in September, but we will bring that back to you to get a layer deeper, because that is the next piece of this puzzle.
Mary Beth?
I just wanted to touch on the pharmacy piece a bit, because I understand that there's a lot that we can't do about things like Medicare pharmacy costs in the state level, but like I think Pat mentioned it in the chat, there might be a federal bill coming, which is really exciting. And I think that if there are ways that we as a committee can either mirror pieces of that bill at the state level, or do something at the state level that's, regarding Medicaid instead of just Medicare, that we should pursue those opportunities, and pray for the best when it comes to the federal level and what the feds govern. So thanks.
Nick?
Thank you. Not sure exactly how to ask it, but echoing that question about behavioral health, I wonder how much of a growth in behavioral health costs are in these or not in these. You know, is this specifically medical, or are those other costs included because payers are more and more required to cover those costs?
Yeah, great questions. So largely behavioral health is included. For, you know, think about any claim that's going to be submitted, it's reflected in these data. Notably, dental is not included in here. That's kind of its own database system, but by and large, behavioral health services would be included.
Ivy?
Hi, Zachary. If I was reviewing that correctly, it looked like inpatient costs were relatively low compared to other costs, and based upon my experience, it looks like costs are being, or care is being given on the outpatient side, which means care would be diverted from inpatient, where you would see much higher costs, which means that care is being done in the right place, at least on a cost basis. That's my perception, having been in other states, multiple states. So I don't know, just food for thought. Definitely food for thought.
No, I think that's right. Overall growth in inpatient is pretty low. The dollar amount is relatively high.
Yeah,
that's because inpatient's complicated, and there's a lot
right.
of labor and machines and technology that goes into that. And in the past 20 years, there's been a pretty significant difference in terms of what has to be done in an inpatient setting versus an outpatient setting, and that's a rapidly evolving space.
Yeah, but I think that's something to look at, because I was surprised to see that.
Yep.
And I'd like to add.
So go ahead, Sarah.
I want to add, as we're having conversations with the individual provider organizations and looking at their data, we're looking at changes in service categories as well. And one of the things that has come up several times now is, ideally, we would see that relationship. Inpatient costs are not growing and outpatient are. I think where we're concerned is that if we're seeing growth in both, without that sort of diversion or care happening maybe in more appropriate places. So that is something that we're seeing variation in across the state, but it's also something we're calling out with individual provider conversations.
I think I just did a quick summary of a couple of comments that I've heard so far. I think both Nick, Melissa's comments, Gil's comments is the shift to primary care also, I think, might be influencing the emergency room utilization number that I think is that was good on the previous slides. And I think up to Ivy's point, right, that getting the right care. So there's some positive items in these and watching these cost growth trends. So Jim?
I think my question may have just been answered, but for example, in the cost increases in professional services, are we able to determine whether, for example, dermatologists are now in short supply and are charging more per hour for their services? Or is it that a particular service is more complex, requiring more hours of work, more time from a particular service?
Yeah, that's a great question. Oh, go ahead, Sarah.
I'm gonna jump in and do something a little bit unique here in this moment, and put some of our insurers in the hot seat here, who have, I assume, watched these trends pretty closely, especially when it comes to their commercial side. So Carice or Angela, do you have thoughts on sort of looking at this data and looking at the professional services line, what you're noticing in your business? Go ahead, Angela.
I was going to say, I'm not sure who you want to go first, but we're seeing both an increase in just unit cost as well as utilization is shifting. So what was inpatient at one point is now outpatient. That's not a bad thing, that's a good thing, but how does it relate to hospital costs? And then relative to pharmacy costs, we're seeing dramatic increases. There's new prescriptions available and they come at a very high price tag. but also the number of people taking prescriptions is increasing over time. So 50% of Americans take a medication of some form. And if you look at Medicare numbers and you look at demographics versus the commercial, you're going to see a vast difference. And one of the things I was going to point out is the demographics within these cohorts are wildly different. And so you should see different utilization patterns in how people are utilizing healthcare. And then also the migration between indie and commercial, for example, or Medicaid, coming off Medicaid into the indie market, there's a lot of transition that happens there. And so year over year, you're looking at different populations, which also makes this difficult as well, because you're seeing population changes. That doesn't take away from the study. It's just something for you to think about as you're looking at the cost basis here. And that also creates challenges back to attribution. So at the very beginning, attribution is hard. It's hard for payers to attribute to a provider. Now think about all the migration between those lines of business we just talked about. So all of that to say it's complex. It can't say it's one thing. It's unit cost, it's utilization, changes in utilization, and how people are migrating in and out of services. And then the underlying efficacy of some of the healthcare spend that is actually taking place. I don't know, Zachary, if you have anything you wanna, if I'm off on any of that, but that's a general view of what we are seeing relative to cost migrating and shift.
Yep, nothing to add.
Great. Carrie, do you have anything to add?
No, I don't have much to add to that. The utilization, absolutely, the changes in utilization, and really for us, we also have a specialty pharmacy company, so we're really seeing that on the pharmacy side. So definitely agree with everything that Angela said, and yes, that is what's trending.
I will say specialty pharmacy is a significant contributor to the growth in the pharmaceutical sector, and commercial carriers, payers, all of them have individual pharmacy contracts. So what you're going to see is a difference in the commercial line versus the Medicare line, for example, where contracting is significantly different. And I could spend probably the next 2 hours on that, but we'll leave it there for high level purposes.
So I think that that's a good flag. And I think also that brings it to the Herdesh's comment. Herdesh, am I pronouncing your name right? I'm sorry. Okay, Herdesh's comment in the chat, I think is important about, are we able to break cost data down between generic and brand name drugs? So when we circle back on this drug conversation. So Melissa?
Yeah, I just had another thought similar to the behavioral health kind of spend and growth, maybe in that area of utilization. I think the other thing that probably is an opportunity to understand better on that last bullet point is around cognitive disorders in the aging population. So not only are we seeing, our population getting older, but then the growth of cognitive disorders and how we treat those patients, right, with dementia or Alzheimer's, and do they show up in an inpatient unit, but that's not maybe the best place for them. What are those resources in the community? That doesn't kind of fit in this whole kind of medical spend component, but they end up in the medical system because of no place to go sometimes for a response. So that's just something else I think that's probably not as well understood or thought through as the population's getting older, those cognitive disorders and what they're causing. When I see the Medicaid inpatient growth, I think that's something important for us to understand and think about as far as medical overall spend.
Hey, Melissa, just sorry to chime in here, but I think that you bring a good point. We should, if it's possible, to age band the spend, into different categories. That's, I think that, we've done a lot of analysis around age banding, and it's very insightful. If we can do that, that'd be great.
Okay, I'm seeing head nodding from Sarah and Zachary that we can age band and look at the in the inpatient. Also, I just want to remind people that We are planning to bring back the prescription drug affordability board to the committee in September to talk about their charge and sort of dig in on prescription drugs in September. Peter?
Yeah, just real quickly, as we think about sort of action steps coming from this kind of data, I want to reiterate that we're going to have to get the behavioral health and the infusion drugs out of the professional services, or we're going to make bad assumptions about where we need to put pressure. You know, behavioral health, especially as we go into 20 and 21, is an area where we're really trying to drive spend and to drive utilization. And so I think we need to parse that out. And then certainly the cost of infusion drugs, as were mentioned earlier, really important to get those out of it so that we can understand what the primary care and the subspecialty inflationary increases really are and where we need to put our efforts.
Okay. Well, I think this has been a very fruitful conversation. I do think that the list of items where we need to break down and come back are quite a few on the staff's agenda item. My suggestion, I think, for what I would like us to see do, and please chime in here if we don't think this is the right direction, but I do feel like we need to dig in around this when we start moving forward on these specific changes. That's when I would expect us to come in with a much deeper, more in-depth analysis on each of these areas before sort of taking action. That way we kind of break down the steps a little bit and the staff have a little bit more bandwidth so they're not coming in with a lot more information on things that we're not going to dig into. Like I think, for example, here, to Peter's last point and to Nick and others' points, we think spending on primary care is a good thing, and we think spending on behavioral health is a good thing. So if we're seeing increases in those spends, we shouldn't send the staff down a rabbit hole to talk about why we're spending more on those, right? We want to spend more on those. And so I think as we move forward on like digging into the specific components and thinking about like the pharmacy deep dive that we're about to do in September, that's an area we're not all in love with spending so much money on, frankly. And so how do we have a more in-depth conversation around that? Other thoughts quickly before we head into our break? Okay, so we're going to take a 10-minute break at this time. The chat is open. If you have feedback for me about how I'm facilitating the meeting or other thoughts from me about how I can do a better job sort of moving the discussion forward, please let me know. I'm really open to that. And I'd just like to remind everybody at this point, I would do so much better if I had a really great co-chair. And so maybe during the break, people can think about why they want to be co-chair with me. That would be awesome. So 10-minute break. I'd like to just give a 1-minute warning as people are starting to get settled in. Okay, I think it's 4 o'clock by my clock. So we have about 70 minutes left on our agenda. And for me, since it's 4 o'clock, the sun is out and it's eating time in Oregon, which means the cherries and the berries and all of that, making delicious afternoon drinks. I'd like to get us out of here on time. So I'm gonna just open it up and quickly kick it off as folks get settled in here. The next item on the agenda is our value-based payment compact and progress. I think what's going to happen is there's going to be a lot of terms that maybe people aren't familiar with during this discussion. And so I want to make sure that as we sort of go through this, if you have questions or something that you're not quite sure about, please feel free to jump in and ask in the chat so we can get those answered. And so we can all sort of stay on point as we move along through this process together. And I'll hand it over, I believe, to Jeremy Vande Hey is going to move us forward on this part of the agenda.
Thanks, Felisa. Why don't we, I'm going to kick over to Sarah here in just a second here. Why don't we go to the next slide?
Sorry, I think we're having a minor internal miscommunication. So I think,
sorry, Sarah, I think I missed my cue here.
There was some prep that we possibly failed to coordinate on. So I think we're hoping that Jeremy can tee up the conversation and just give everyone a reminder about why we're talking about the value-based payment work with this cost growth target committee, where this work came from, why it matters, why we're bringing it back to you today. Then we're going to go to Summer. Summer's going to give us a little bit of grounding in value-based payment, what it means, what it is, what we're talking about around the value-based payment compact. And then we're going to hear from one of the tri-chairs of the value-based payment compact work group to talk about what that work is looking like. And then we're going to talk about where this is all. Then we're going to talk about how we are doing in Oregon on terms of progress on value-based payments. So Yishan Sung from my team is going to present some data on what value-based payment in Oregon looks like using our most current data. And then we're going to talk about where this work is all going and how it continues to intersect with the Cost Growth Target Advisory Committee. So I think that is the arc of this conversation, a lot of different presenters, but we really want to make sure that everyone who is coming new to this conversation and maybe doesn't have the history of why we're even talking about value-based payment work with the Cost Growth Target Committee has that before we dig into where we're going next. So Jeremy, does that tee you up?
Perfect. Give me plenty of time there to try to figure out what I'm going to say. So thanks, and good thing I like winging it. So just a bit of background here. You know, one of the things that we have sort of said about this program, the Cost Growth Target program, is that, you know, measuring growth has been important, but that's sort of like a point in time on a single day, and what are we doing the other 364 days a year to try to figure out how to get costs under control. And Michael Bailey at the last meeting presented sort of a annual cycle kind of circle of measuring, but then having that really lead into conversations of, and what do we do about it? We had a series of initial conversations with the implementation committee around, are there some things out of the gate before we've even started measuring that would be most important to sort of get off the ground to be able to get our arms around costs? And we looked at a whole variety of things. And the thing that the committee came back to over and over and over again was getting away from fee-for-service and moving to value-based payment. That sort of everybody knew that was going to be a thing that we needed to do as a state, and lots of states are trying to do that, and there's lots of countries trying to do that. So the group, the implementation committee, came up with the idea of an approach that would be sort of a spin-off strategy that would run in parallel to the cost growth target, but was sort of also its own unique body of work of really more aggressively trying to move from fee-for-service to value-based payment, and recognize that we've been talking about that for a decade and have made progress, but have not sort of gotten to the finish line, and in a lot of areas have not made as much progress as we'd hoped. So the idea was to come up with a voluntary compact of payers and providers from across the state, from across markets, to commit to a series of targets. And part of the reason for the idea of the compact was sitting in my chair with an OHA, I would frequently hear from payers, I would like to get to value-based payment, but I can't get the providers there. And I would hear from the providers, I'd like to get to value-based payment, but I can't get the payer there. So this was a little bit of, are we all in this together? Are we really there? And can we sort of hold hands and figure out how to get there in a collaborative way? So the implementation committee came up with a series of targets that you hear about more from other presenters. Pretty aggressive targets. This was earlier on in the pandemic, and there was a lot of debate about that. But the idea was, let's sort of stretch and let's pick some targets, and if we need to adjust, we can adjust, but let's really try to stretch ourselves and make some significant movement. The other piece of context was this was also, which we're kind of coming back around to now a year and a half later, this was also early on in the pandemic when a lot of providers were really struggling, and there was a lot of discussion of, if we were on a much more capitated value-based payment system, we would have actually been in a better financial situation as a healthcare system going into the pandemic, when we were stopping elective surgeries and things of that nature. So the implementation committee came up with the targets and then tasked OHA with seeing if we could get seeing how far we could get in terms of a broad commitment. And there wasn't really you need to have exactly these folks, but it was, let's try to get as much of critical mass as we can. I think we're actually really proud of the progress that we've made. We've gotten every major payer from every market across Oregon. We had the Hospital Association, as well as many of the systems, as well as many primary care providers and others signed on, as well as all of the state's lines of business across health insurance marketplace, DCBS, PEB, OEB, Medicaid. So that's really where this stemmed from. I will say it's been confusing because there are two parallel bodies of work happening. That while there's sort of accountability from the state around cost growth target, there's not sort of a penalty for folks not doing this. It really was designed as something that is needed for us to be successful as a state, and also a way for folks to demonstrate that they're making progress towards the cost goals. But it is a body of work that's running sort of in parallel to a lot of our cost growth work. So Sarah, back to you.
Let's go to Summer for the rest of the framing. Thanks, Jeremy.
Great. Thanks, Jeremy. You can go to the next slide. Jeremy just walked you through this. This is kind of how we got to the VBP compact. So next slide. So just a little bit about value-based payment, and I'll try not to use too much jargon and explain things as I do. So value-based payment is really changing the way we pay so that we're not paying for just for when services or when visits happen. I mean, that most of the payment, the way healthcare is paid for now, is a service is given, a person goes in for a visit, they go to the hospital, have a stay in the hospital, everything gets billed as an individual service is provided, which incentivizes the provision of more services. And you probably notice when you go to the doctor, the visits are short because the more visits that primary care doctor or any doctor can, but especially primary care, because so much of what they're billing is the individual visits. There's not a whole lot of procedures happening in primary care, or less than in some specialties. It's more visits. And so the more visits they can have, the more payment they can bring in, and means shorter visits and cramming more patients in, which isn't great for patients and isn't great for providers either, and isn't great for quality or equity of care. So when we change the way we pay to be more flexible and pay for quality and the outcomes of care rather than the volume, then we can get better outcomes and provide care that is person-centered, evidence-based, and can lower the cost of care, or at least having care be provided where it's most appropriate, and hopefully where then it's also at least expensive when you're not getting people, you're getting people into primary care rather than getting them into the hospital, for example. And it also can cover, because it provides some flexibility, so you're paying in a different way than paying for services, that other aspects of care that are currently not covered by fee-for-service but are very valuable can be covered, such as emails to patients. We don't always need to go into the doctor. We can get questions answered via email, but there's not a billing code for that. A provider isn't getting paid for the emails that they provide between patients, or they're not getting paid, for example, for consultations between providers. So maybe you're getting your care in primary care, but there's something that a patient comes in with that's more complicated, and the provider needs to talk to a cardiologist, for example. There's no payment for that conversation or consultation between one doctor and another. And then to be value-based payment, there has to be a link to quality. Next slide, please. So value-based payment models leverage three interrelated features that are really important for advancing quality and health equity. Those are care delivery redesign, payment incentives and structures, and performance measurement. They hold provider organizations accountable for delivering better care and achieving better health outcomes for all people, give providers that greater flexibility that I was just speaking to, and increase accessibility and use of effective, appropriate, and affordable care and services. Next slide, please. So this is a really, there's a lot on this slide, and I don't think we need to go into too much detail, but this is an important framework that was created by a public-private partnership, including CMS, to lay out what different payment models look like. And you'll see that on the left, category 1 is what so much of healthcare is paid for now in fee-for-service, where there's no link to quality or value. A service is provided, the provider gets paid, no matter what the quality or value of that service. Category 2 starts to shift that. There's starting with foundational or infrastructure payments that can support things like health information technology or care coordination. There's not a tie to quality, but there's really it helps providers get ready to be able to take on more advanced payment models. Category 2B is pay for reporting. So you're starting to report, but you're just getting paid for that reporting. And then C is when you start getting into a real focus on quality. So there's pay for performance. Some of the payment that is made to a provider is based on the quality of care. And then category 3 is more advanced. You're looking at, there's an opportunity for shared savings. So if care is provided at a lesser cost and quality stays the same, there's the payer and the provider share that savings. In category 3B, it's a savings and risk. So if costs are higher than predicted, some of the payment would be at risk at the provider level. And then category 4 is really population-based payments. And those could be a full comprehensive, kind of what we think of as capitation, but with a direct tie to quality, or condition-specific payments. So like a bundled payment, all payment related to a specific cancer diagnosis or maternity care, those types of payments. Yeah, next slide, please. So I'm not sure Liz has joined us yet.
I'm here.
Oh, you are, great. Okay, I'm going to hand it over to Dr. Liz Powers from Winding Waters Clinic in Enterprise, Oregon, to speak a little bit to what value-based payment looks like and how it's impacted at a clinic level.
Thanks, Summer. I'm glad you all can hear me. So we are a federally qualified health center in the northeast corner of Oregon, and we have a population in our community of about 7,500 people, and we have providers. So we have, I think, 10 PCPs, but to put that in a little bit of a context, our providers do clinic care, home care, hospital care, nursing home care, ER care, and do procedures and deliver babies. So the FTEs are a little bit skewed if you think about the comprehensiveness of the care they're providing. Summer, I don't know if you want to take it off the share screen so people can see faces, but I want to provide you just with a quick overview of what we're doing in the VBP realm in our small practice. And then
if you could take down the slides, Brian, that'd be great, just for a little bit.
And then opportunity for questions if that's appropriate, or if you have any, and Summer, you can sort of take the lead on that. So want to start out with talking about the Medicaid population, then the Medicare population, and the commercial population. And then I'll give you a couple of my reflections on what's working well and sort of where our challenges lie. So for our Medicaid population, we have agreements with EOCCO, who is our Medicaid provider. We have capitation plus upside risk and pay for performance for the medical side. We have capitation only in a very small PMPM to encourage integration from the mental health side. And then we have capitation plus pay for performance. So that's bonuses upside only for dental. In all cases, we have a capitated payment and with some additional quality bonuses for dental and medical and no quality bonuses for mental health. On the Medicare side, we are, for straight up Medicare, we are part of an ACO, and through that are able to gain access to shared savings. So those are quality bonuses, upside only. And then for Medicare Advantage, we have an agreement with one Medicare Advantage plan that pays for performance. So upside.
I'm just hoping some other folks who are on the call could just everybody check their mute, please. Thank you. Sorry, Elizabeth.
No problem. I just was trying to listen to see if people had questions. Yeah. And then on the commercial side, we have an agreement with one commercial plan which pays for performance. That's a quality bonuses for upside risk only. And so we'll sort of get to that in a minute with the challenges. So what works well is when we have lots of covered lives with a particular insurer or payer, like the Medicaid population. So when that population is greater to or equal to 10% of our attributed patients, that works well. It's easier to manage. And then it works well when there is alignment across payers, multiple payers of the quality metrics, because we have different quality report. I think you heard me say with each of those buckets, Medicaid, Medicare, and commercial, many of the VBP agreements focus on quality bonuses and upside risk. And those quality metrics are different for each of the payer sources in many cases. And in some of the cases, it's, well, we'll pay you for good diabetes control, but we're going to define it differently depending on who your insured provider is. So it works well when there's alignment of metrics, less well when there's not alignment of metrics. And then what also works well with VBP is the payers supporting our team with accurate, actionable data. So when we have monthly meetings with our EOCCO, for instance, or with our Medicare Advantage plan provider, where we look together at the metrics and talk about what our challenges and how do we reach target populations. And we're really collaborating together real time in improving outcomes. So that works really well. Our challenges are that there are a growing number of payers and plans that cover our population. So again, I told you 7,500 people in our community, and our community health center billed 221 plans in the first 6 months of 2022. And so that is not only a huge administrative burden, it's really fragmenting our market, and it makes it really difficult to achieve a 10% threshold. That really sort of makes the complexity of adding on the VBP arrangements worthwhile, especially if we're looking at something with a downside risk. And then, as I referenced before, having different quality metrics with varying and disparate reporting requirements is also a significant challenge. And I think maybe by far the greatest challenge is that as a small organization, we have little leverage, little expertise, and really zero room for contract negotiation. We mostly just take what we get, and we wonder if we're getting paid less than others while delivering quality care, or sort of what this looks like. And we have sort of very limited ability to influence what might be in those VBP contracts. So that was just a really high level, very quick overview. And I'm sure that I can add more if you have particular questions, or Summer, if you had other things that you were wanting me to share.
No, that was great, Liz. I think you shared that the value of VBP and also the challenge, and why the compact, and what's an important reason for the compact is that that folks want to, providers want to do it, payers want to do it, although they both will blame each other, point to each other as challenges or barriers. And there are significant challenges for providers when it's different across different payers. And so thank you, Liz, for sharing that. Next, we're going to look to just real quickly look at the data that we have in OHA, showing where we are as a state and at different lines of business, as well as different payers in implementing value-based payment. So I think Ishan.
Hi, I'm Ishan Song. I just want to confirm if anybody looks my, okay, sounds good. So hi, good afternoon. I'm Ishan Song, a research analyst with Costco's Target program and the OPAO claims data reporting program, which we call the APAP program. So today I'm going to just briefly walk you through this VBP data, focus on where the data is from, what kinds of data we are collecting for the VBP report, and how to interpret these numbers. And if we have time, we may allow some questions. So the VBP data, so could you still see my screen correctly? Okay. The VBP data is from the APAP program, which we call it payment arrangement files. In addition to the healthcare claims data, since 2017, APAP program starts to collect the payment arrangement files from the carriers and CCOs, and it is the contract-based payment data. It contains the payment data from carriers and CCOs for all the contracts cited in Oregon. So cited means the policy is sold or issued in Oregon. The payment arrangement file is not the claims data, and it is not the medical records. So there's no individual member or patient data there. It is the payment data by contract, by payment category, and by market from the payers. Before we go to the numbers, I just want to give you the overview of the methodology, how the data are being reported. So as Summer just mentioned, the HCP lane category, the payment arrangement file using the HPC lane category with one additional category, which is called 1A, fee for service linked to the APM payments. So as you know, there's some hierarchy structure for the HPC lane categories. The lowest the categories are the payment not linked to the quality. And the most advanced the payments are the population-based capitation linked to the quality. So as I mentioned, the payment arrangement file is the payment by contract. It is very possible that one contract can have payments under multiple payment categories. In this case, we will sum up all the dollars into that contract and attribute the sum to the highest category in that contract. It is also possible that some of the payments is the negative value, which means the provider pays the money back to the payer, the carrier. It could happen for the risk sharing type of payments. And for these kind of values, we will use the absolute values. So all the negative dollars will be converted into a positive value. So we don't want to deflate the VBP components. And one last thing before we jump into the numbers. So one contract can be lasting for multiple years because we do the VBP report annually. So the data would be prorated for a certain reporting year. So let's jump into numbers. So now you are going to see the VBP data in 2020, which means the payments for the services provided in 2020. Let's start from the Medicaid CCO's data. We have the CCO's data separated from the other markets because both medical and dentals are the covered benefits for the CCOs, but for all other for other carriers, we only report the medical payments here. So if we use the 2C or higher to define the VBP, which aligns the CCO 2.0's VBP goal, they are about 46% of the CCO payments are considered as the VBP, which meets the 20% of the target in 2020 for the CCO 2.0's VBP goal, although there's one or two CCOs do not meet this 20% target. And the drop-down list here, you can select different definitions about different payment categories, how you define the VBP. For example, you can choose payment 3A or higher or 3B or higher, and then you will show, you can play with the through the link we just show you. Just play it. So that's for the CCO. Now I want to move to the market level for the other markets. So at the market level, if we scroll down for the bottom graph, the other markets means we include the commercial, PAP and OAP, and Medicare Advantage. For just the data at a high level, we see the commercial has about 54% of their payments are VBP, which means the payment category 2C or higher, and then PAP is 52%, and Medicare Advantage is 43%. You can use the button here to switch the data between the market level or a carrier level. So for the carrier level, if you scroll down, you can play with it again. If you want to choose a different payment category as the VBP, you can do that. Here, I just want to give an extra note for the Kaiser. Although you see the Kaiser here, it's 100% VBP, but Kaiser just resubmitted their VBP data 2 or 3 weeks ago. Although most of their payments are under VBP, but they do have a small portion of the fee-for-service which are paid to the providers outside the Kaiser system. So we will update that later this year when we have the data available for the analysis purpose. So that's just the overview of the data. Any questions?
Thanks, Ishan. This is really helpful. I think, oh, and thanks, Zachary, for dropping the link into the chat. Great. If we can go back to the slides, that would be wonderful. Great. And oh, there we go. Next slide, please. Thank you. So here's the VBP compact. Jeremy spoke to it. The commitment that payers and providers are making is with the purpose of lowering the rate of cost growth, fostering health equity, and improving quality and outcomes. And they're doing that by expanding innovation, learning from early adopters, removing barriers, and expanding knowledge and awareness. And while as Jeremy said, while the compact supports achievement of the cost growth target, the cost growth target is not the emphasis of the compact. The emphasis is on increasing the use of value-based payments, which with the goal of multiple goals, but one of which is lowering the rate of cost growth. Next slide, please. So again, as Jeremy said, the Sustainable Cost Growth Target Implementation Committee, sort of the predecessor to this committee, developed the recommendation of the compact and some principles to guide the compact, and kind of a quick summary of those. It's the principles focus on the spread of advanced value-based payments, which are defined as shared savings, which is that category 3A in that framework, or more advanced models, so including shared risk, condition-specific population-based payments or capitation. The implementation committee prioritized prospective budget-based and quality-linked models when feasible. These provide some upfront, usually a per member per month payment, which helps providers with predictable payment and also that flexibility. There's specific targets that I'll share in a future slide, and the implementation committee principles included specific expectations that advanced value-based payment models should be designed to promote health equity, as well as to mitigate any adverse impacts on populations experiencing health inequities. Next slide, please. So as Jeremy said, here's where we are right now with the compact. We've had 47 signatories, including commercial payers, Medicaid, Medicare Advantage, health systems and clinics, provider organizations like the OMA, the Oregon Academy of Family Physicians, and those represent 73% of Oregonians are represented by the compact, and we will be reaching out to additional organizations to increase the number of signatories. Next slide, please. So here's a list of all the signatories. I'm not going to read through them. I know you have these slides, but it's a good list. You'll see on the far right, there are health systems, not individual hospitals. Again, we'll be reaching out to a number of different organizations with the hope of getting as many signatories as possible. Next slide, please. So here are those specific compact targets. So there are two sets of targets. One is for all payments, and that all payments would be under advanced value-based payment models. Again, that's defined as the shared savings or more advanced models with a rate of growth of 35 to 50, 60, and 70%, and then a specific another target just for primary care practices and general acute care hospitals that is shared risk or more advanced. So shared savings would not be able to fit into this category, and those increase up to 70% by 2024. Next slide, please. And so partners convened to develop a work group to ensure that this work moves forward. The work group was convened or co-convened by OHA and the Oregon Health Leadership Council with support from the Hospital Association and OMA. The work group has identified opportunities to accelerate VBP adoption, articulated challenges to adoption, and recommended strategies, including policy changes to address those challenges. And I'll go into more detail on those. And it will then support implementation and monitor and report on progress. Next slide, please. So here's from the charter of the work group. It's to, as I said earlier, to accelerate the adoption of VBP. And the deliverables are a roadmap that has been developed, and I'll go through that briefly. And then we're in the process of developing an evaluation framework to monitor progress, and there'll be annual public reporting on the implementation of the roadmap and progress. Next slide. The work group is 15 members with representation from health plans, providers, PEB, OEB, and OHA. Next slide, please. And the work group was formed by, it was convened formed by the convening organizations, the Hospital Association, OHA, OHLC, OMA, and PEB, which developed a charter that guided membership selection. And so you can see the 4 bullets of each of those entities selected 3 representatives at their discretion, and then once convened, the work group members were selected an additional 3 members with the focus on those that have expertise in health equity. And the duration of membership is through 2024. Next slide, please. And here are the work group members. And the work group it's not an OHA, it's co-convened, so it is not a public entity, and it was not established by legislation, even though it is connected. It was identified as a way to support the achievement of the cost growth target. It is, as Jeremy said, it is its own entity. Although it is not a public entity, the work group has a strong commitment to transparency and keeping the community informed and engaged in the work. Next slide, please. The work group is also keenly aware of other things that are happening in the state to impact value-based payment and cost growth, and is closely aligning with those, including this advisory committee, work by the Primary Care Payment Reform Collaborative, CCO 2.0, activities around health information exchange, and other opportunities for multi-payer alignment. Next slide, please. So one of the first things that the work group did was focus on identifying what are the challenges to value-based payment, and Liz Powers spoke to those, and there are multiple challenges, and they're not insignificant, and that was really where the work group needed to focus first. So some of those are really just the transition from a fee-for-service system to value-based payment models, that a practice, a clinic or a hospital that is used to operating under fee-for-service, changing that payment model requires significant infrastructure change, as well as it's a really a cultural change and thinking about how payment is different. That there are multiple VBP models. Liz definitely spoke to that. The ongoing pandemic. There's a concern about financial loss. Data infrastructure is really important if you're reporting on quality measures, and there's a lack of data infrastructure in many organizations. Meaningful risk adjustment is a concern, and small patient populations, as Liz spoke to, and diverse attribution models. Next slide. So the work group identified 6 set strategies to accelerate VBP adoption, and I'll go briefly into details about those, but it's a short menu of VBP models, a VBP toolkit focusing on equity, strategies to mitigate financial risk, policy alignment, and attribution. Next slide, please. So the first strategy is developing a short menu of value-based payment models for use in Oregon that are developed by and reflect the priorities of key stakeholders and allow for greater model alignment between payers, including value-based payment models for primary care, hospitals, and specialty care. And that this will one way to address that transition from fee-for-service to VBP and the multiple VBP models. Next slide, please. So the key action steps to achieve this strategy are the development of value-based payment models one for primary care, for hospital care, and for specialty care. And the timeline, you'll see the primary care payment reform collaborative, a multi-stakeholder entity that has been convened by legislation and meeting since 2016, is in the process of developing a VBP model for primary care that will be presented to the compact work group by the end of the year. A group of hospitals and payers will begin meeting later this year to start development of the hospital VBP model, and payers and specialty providers will identify a priority care delivery area and a process for developing a specialty care VBP. And the indicators of success are participation and increased adoption. Next slide, please. So a VBP toolkit was something that was a strategy that was as early identified by the work group. One that would inform, support, and encourage provider and payer entry into value-based payment. And it would address those challenges listed there. Next slide, please. So a development of a compendium of VBP tools to inform, support, and encourage provider and payer entry into value-based payment models. It will include building blocks, sort of those elements that are foundational aspects of any or most value-based payments, such as focusing on quality metrics, building that data capacity, workforce considerations for VBP, equity, geography, and risk, and processes for implementation of the short VBP menu. So that really is, there's kind of those two components of the work group, of the toolkit, one being those elements that are important to any VBP model, and the other specifics around implementation of each of the short VBP menu models that have been identified. In the spring of 2022, the work group surveyed payers, health systems, hospitals, primary care clinics, and specialty care clinics to understand the status of VBP adoption, as well as identify possible opportunities for or what activities would promote and move forward with value-based payment adoption in Oregon. And what we learned is that what was needed, or what was identified as things that would support increased value-based payment, were the same things that are outlined in the strategies that I'm speaking to now, and that in sort of the back of the envelope, rough estimate of the status of VBP adoption across the state really supports what Yishan just shared with the APAC data. Next slide. Targeted explicit strategies to integrate equity considerations into all VBPs is critical to this work. That we're sort of figuring that, learning from other states and what's happening within Oregon to identify those strategies to address the challenges of data infrastructure and meaningful risk adjustment, which are critical to integrating equity into VBP models. Next slide, please. So the key action step for this strategy is to review and apply the equity principles that were developed by the Cost Growth Target Implementation Committee to components of the VBP toolkit, including those VBP models and building blocks. And that an indicator of success is to see the increased adoption of equity elements in health plan agreements across markets. Next slide, please. So strategy 4 was mitigating financial risk. That it was clear from the work group conversations, as well as the survey that the work group conducted, that there are providers have significant concerns about financial risk and loss of income that can happen with the implementation of VBP models. You will hear that providers are often not happy with fee-for-service billing, that they understand the challenge, the barriers that poses to the quality of care that they want to provide and that their patients want to receive. However, it's it's the devil you know or the devil you don't know, and fee-for-service is what people know, and so there's a lot of concern about changing that and the significant financial loss that can happen, particularly if there's not meaningful risk adjustment, and it's a big barrier to transition from fee-for-service to VBP.
So Summer, I'm
Yeah.
sorry, I'm gonna just jump in here
Yeah.
because we are running.
I know.
Very, very far behind.
Yeah.
So
Let me,
so just quickly, so I think that this could be potentially a pretty robust discussion because it's our first strategy out of the gate here around these value-based payments and the compact that was signed. So my suggestion for what we do is that we have Summer finish these slides and that finish the sort of key strategy components. That if Gil, if there's, you're the member of this committee and the value-based payment committee, so if you have something that you'd like to share or add, I think we'd want to do that. Then I'd like us to come back in our next meeting to actually have a conversation about how we support moving this forward. What I also want to encourage people to do in this conversation too, is if you have current questions or things that you'd like the staff to dig in on before we come back for that conversation, if we could put those in the chat or you could email them to Sarah in between so that we can come back with a sort of more full and robust discussion. You know, frankly, this is our first strategy out of the gate. And so I want this to be successful. And I think we all want this to be successful. Does that sound like a good roadmap for what we'd like to do for the rest of this meeting?
That sounds great to me.
Okay.
Yeah.
Great. So not seeing any objections or hearing any objections, that's how we're going to move forward. And then I will encourage us, Sarah and Zach and Summer, to send out materials in between the meeting as soon as we get them so that people can read them and be prepared for the next discussion. So
great.
Right, Summer, sorry,
Thanks.
go ahead.
Yeah, I'm going to move us through. Okay, so next slide. Well, so that strategy 4 is mitigating financial risk and developing some tools around that, communication with providers. Next slide. Actually, let's go to the slide after that. So data and policy alignment is key, a key to this work. And so the work group is aligning with the Health Information Technology Oversight Committee around data collection. And I'll speak to this in a second, around what OHA can do in terms of aligning value-based payment across our lines of business. Let's go to, let's see, next slide, the slide after that, and the slide after that. So here's a lead entities for some key action steps. So as I said, we're in the process of developing the primary care value-based payment model. That's the Primary Care Payment Reform Collaborative. The hospital model will be the Hospital Association and the Oregon Health Leadership Council. The specialty model will be the OMA and others. That one's slower in development. The toolkit is a lot of partners that applying the equity principles is really sits. It'll be a lot of partners, but the lead sits with the work group itself. And then OHA is working to make the value-based payment compact targets required for the lines of business that OHA has responsibility for. So the CCOs, PEB and OWEB, and the marketplace as it's possible. And those will happen over time as, you know, in alignment with contract cycles. Next slide, high level timeline, a lot going on. Big picture is this runs through 2024. And you'll see that the menu of models is staggered, as is the toolkit, and equity is integrated along in each of the models is developed. So yeah, next steps of the roadmap, and I know Sarah sent out the roadmap with the agenda and other materials for this meeting. We're in the process of getting the roadmap disseminated through a variety of partners. We're happy to present to anyone that is interested in diving deeper into this, and we will share more at the meeting in September, and really look forward to a robust conversation about that. But if you have, if you want more detail presented to your staff or other stakeholders, we are happy to do that. And then the primary care payment model has been launched, the model development, and I'll give you a quick update on that. Next slide, please. Oh, slide after that, sorry. So the primary care payment model is, they have made some preliminary recommendations, still finalizing things, but the idea is that it'll be a prospective payment model. So some of the for some of the services, that payment will be made upfront, like a capitated payment, and that they're decided, or I think mostly decided, that it'll be a phased in approach, starting with early adopter practices that are ready. It'll be available to any practice size. There has been a lot of discussion about how to integrate the PCPCH recognition into the model, and some decisions still need to be made on that. Next slide. And then in the coming months, they'll be talking about incorporating equity, attribution, sort of all these, what does risk adjustment look like for different, adult versus pediatric. There's a lot of interest in social risk adjustment. It is a nascent strategy that many across the country are interested in, but there's not a lot of experience yet. As I said, it'll be a model that the prospective payment will cover a lot of services that are provided in primary care, and there will be some that will continue to be paid fee for service, because as great as value-based payment is, there is a role, I think, always, for at least for the foreseeable future, for fee for service. Fee for service does incentivize action, and so services like childhood immunizations are a great example of services that we want to promote, and that keeping those fee for service has been effective in ensuring delivery of that care. So next slide. Here's the website, the link to the roadmap, an email for you to stay connected. I know I just went through a whole bunch of stuff really fast. And again, I really look forward to a conversation in September, because this is a strategy that you all identified as a way to achieve the cost growth target. And the work group wants to work together to achieve that.
So I just want to give Gil a minute to jump in here if you have anything to add.
Well, congratulations, Summer, on covering a lot of ground, and Liz for leading the group. I think, as you can see, this is a great complement work to the work of this committee. But we shouldn't underestimate the challenge of building the infrastructure for provider groups and relationships with payers to really make these models successful. So many of the items that Liz covered, are very resonate with a lot of providers in terms of building the data infrastructure, considering the risk factors, and in my mind, one of the key things is how do we overlay the health equity lens with this, because you can move to a value-based pay, lower costs and everything, and do that completely separate from an equity perspective, but I think that this group is really looking to incorporate that, and so I'm looking forward to how that develops. And so looking forward to more discussion about this in the future, with this committee, about how we can move these forward in the context of the work of the cost growth target group. Thank you.
Well, I think thank you, Gil, for serving on both committees and keeping us connected in this process and the presentation. So we have about 5 minutes. And so I think we have 2 robust topics that are going to come back to us in that September meeting they're going to be pretty highly technical. So this VBP topic is coming back to us, is a very technical topic. And I think as we were going through this slideshow and looking at the data that was presented, I know I personally have a lot of questions. I assume others have a lot of questions or thoughts. I think it would be good to get those to Sarah so that we can collect those and be prepared to answer them and answer the questions, and at least be prepared to sort of see some common ground on our thoughts on this VBP implementation, because as both Gil and Summer pointed out, we're a key partner in sort of helping to drive this forward. The other piece is the pharmaceutical discussion, and that is also going to be robust and meaty and very complex. And, you know, I think that there's going to be a lot of questions about what we should try, what we can do, what we can't do, what we legally can do, what we legally can't do. And as always, what can we force the federal government to do, which is a question at the forefront of everybody's mind almost every day nowadays. So I think as we head into September around that conversation as well, we're going to have an outline. I'm going to put my my personal information in the chat. So my email address and cell phone are in the chat. If you have feedback for me on the facilitation of the meeting or the meeting overall, I would love to hear it. Again, I'm still looking for a partner. If anybody nominated themselves during the break, I also would love that or want to nominate themselves. And I think Sarah also would be interested in the feedback on how this meeting went and the previous meeting, so that we can really structure these moving forward. And I really hope that we have a more participatory meeting similar to we did in the beginning. That means we're going to have to sort of cut our topics a little bit and take a lot of time. So Sarah, is there any other additional wrap up you'd like to do?
2 things real quick. We do have a September meeting scheduled and we have a November meeting scheduled. It's on November 9th, which was pointed out is the day after the election. And maybe that's not a great day for some folks because you'll be busy or will have been busy. So I think a question is, do we want to try to reschedule November to something that is not the day after the election? General, can we try to look at calendars again for November? I'm seeing no head nodding or shaking. I take that as a neutral. Maybe we can try. Okay, well, let me see what we can do about that. And then the second thing, we had a comment about the report that we spent the first part of the meeting on is very technical, and there's a lot of information in there. And maybe some folks would appreciate the opportunity to walk through it in more detail and just sort of have a more guided tour of the report. And I think we could set up an additional hour that would be an optional time for committee members and possibly the policy board if they wanted to join us to walk through that. So we'll see if we can get something like that scheduled just as an optional time to spend a little more time getting familiar with that data, if that sounds good to folks. Okay, great. Thank you.
Great. I also think the other component of that is I do want to encourage folks to use this VBP compact at state.or.us if you have general questions about the value-based payment. Also, the Medicare, the CMS site and Medicare has a lot of information too, and that just sort of describes the basic sort of value-based payments 101, which I've had to read several times to get to the level where I can understand that. So I think if people have questions or don't understand something, I think it's really important that we just ask. It's totally fine. We're an expert here in what we're an expert in. And so we should ask the questions about what we're not. So I hope that people feel comfortable to do that, either in the meeting or between the meetings or one-on-one or in the chat. So with that, I think we're wrapping up. Okay. Enjoy the sunshine, everyone. Thank you for your participation.
Thanks so much, everyone.